Okay, thank you.
Thank you very much on behalf of all of us for coming today.
Okay.
Great. Right. Well, good morning, everybody. My name is Sarah Wallace, and I'm the chair of the NHS Devon board. So welcome to our public meeting today. I'd particularly like to welcome Bill Shields, who joins us today as Finance Director, and Anthony Fitzgerald, who joins us as Chief Delivery Officer. You're all very welcome. We have apologies today from Kate Shields from Cornwall. Just a little note to ask everyone if you could keep comments using the chat bar to a minimum, because not everybody can actually see what's within it. And I also promised that I would update people who are viewing from outside with what we're going to have in our private session later. So we'll be discussing an oxygen contract, which needs to be held in private because of the bidding process involved. And we'll also be discussing some aspects of our developing primary care strategic framework. And that's because it's still at a very much a discussion stage, but we're hoping to bring it back to a public session as soon as possible. Next thing on our agenda is declarations of interest. And I wonder if any colleagues have any updates to the declaration of interest as published on our website. No? Thank you very much. And we've had a request to correct Tracy Lee's title. So apologies, Tracy, that we didn't have that correct to reflect that you're Chief Executive of Plymouth. Going to come first within our meeting. It's a really important part, which is hearing experiences from people who have been using our services. And I'm very grateful to Mr. Robert Cox, who is going to speak to the board today about his experience of using services in the emergency department in Barnstable. So thank you very much indeed, Mr. Cox, for joining us today. And I'm going to go over to you for you to tell us our story, and then we'll be hopefully able to respond. Thank you very much.
Okay, so on the 18th of August, I found myself on the floor at home, coming round basically, and I thought I'd fainted and I couldn't get up, and I had to crawl across the floor to help myself get up, and I just sort of at that point discovered that my right leg was, I don't know what I'd done, hyperextended it or twisted it, something had happened. And I'd also bashed my head on a door frame, and I managed to get up, and my wife came, and we weirdly had guests turning up. So I spent the whole time sort of trying to act normally, explaining that I thought I'd fainted, and I'd never fainted in my life. I was clammy, and just it took me a while to sort of start acting reasonably normal. So that the next morning I got a call from the cardiorespiratory department at Barnstable Hospital to say that I have a 24-hour monitor and a defibrillator, ICD, implanted, that there'd been an incident, and could I describe it? So I told them what had happened, and it was that the ICD had shocked me, and I should come in straight away to A&E for blood tests, etc. So I turned up at the hospital. I went by taxi to the hospital, and I was there by 10 o'clock in the morning, and ended up staying there for 36 hours in the waiting room, being you'd sort of shunt yourself from one end to the other just for a change of scenery, and various tests were done, and the coffee machine didn't work, none of the machines worked. You daren't leave to go and buy yourself a cup of coffee, or in case you missed the call from a doctor or a nurse for a test. And the whole thing became such an ordeal. There was no bed to put me in, basically, was the problem. But there was a sort of great lack of information about anything. You didn't feel that you could ask a question of anybody because everybody was so busy dashing around doing their thing. Lots of other patients you meet there who've waiting 4 or 5 hours, and it just seemed that me and one other lady were just there for so long, and at night, there was nowhere to lay down. he just desperately wanted to lay down. And eventually, about 2 o'clock in the morning, they put me into a little side room down the corridor, which I presume in the daytime is a clinic. So it has a bed in there, not a bed, but a couch thing. So I laid there for about 3 or 4 hours. And then I had to get up because the hospital was coming back into operation in the mornings, back into the waiting room where I sat that whole day again until 10 o'clock at night when I could be admitted to the, which department is it called? Medical Assessment Unit. So eventually I got there, where I was there for another day and a half before I was put into the cardiac department because they said I needed to go to a heart monitor. So I'd actually been there for 3 or 4 days before I even got on the heart monitor. And it transpired that I'd had a cardiac arrest. And obviously my life had been saved by the fact that I had this defibrillator. It was the first time it had ever gone off since I've had it implanted. But from then on, your mind just does, the anxiety and fear of it going again, not knowing why it went again, why the defibrillator fired. It's just extraordinary. And I've had to go for psychological help, to be honest. Every day I just wake up fearing this thing will go off again. And I just felt so, the A&E experience is only part of the whole thing, but I still can't understand why I was in there for so long. And there's no technicians from the cardiorespiratory working on weekends. So there was nobody there to come and check my device to find out why it had got off. That's straight away, that's 3 days worth of waiting for the pacemaker to be checked out. To this day, I don't know why it went off. Nobody's ever really explained it to me. That's my experience.
What I'd like to say first of all is how very sorry I am, and to apologise to you on behalf of all of us that you had such a dreadful experience. It is totally unacceptable that you had to wait for 36 hours and that there were such delays in your treatment. And I can completely understand that the episode itself must have been profoundly upsetting and to have ripples today for you. So I'm sorry that you didn't receive a faster response. And I know that there are a number of colleagues here today who would like to be able to give a response to your experience. And I'm going to first bring in Darren Alcorn.
Yeah, thank you, Chair, and thank you, Mr. Cox. Clearly, an experience that is far below what we would expect. And again, I would pass on my personal apologies to you for that length of stay, and particularly length of stay in a waiting room in our emergency department. And I think for me, the concern that the wider board have, that this is a all too frequent occurrence that we hear in terms of our emergency departments. The fact that you were contacted quite rightly, as a fact of a digital monitoring, which actually is a really effective way. So I hope, but ultimately then, despite that trigger, the response beyond that has clearly not met any of our expectations. So the work that we're doing, particularly with each of our providers, so obviously in this particular case across North Devon would be the Royal Devon next to University Hospital. Trust, ultimately working with our colleagues around understanding and improving the medical pathways. Because ultimately this, as you were saying, medical assessment unit and cardiology is around making sure that we can work and get the best practice across all of our systems in Devon to make sure that those elements are addressed quickly. I think also working with our partners, I think also understanding a little bit more of the background to the situation is, I think, we need to make sure that we support our organisations to respond quicker to areas of concern like yourself. So in terms of addressing the complaint, and I think you've already quite articulately put in there that ultimately you are a number of months down the line now and still don't really understand why you ended up in that particular position, which again, I can understand, the psychological harm that has had and continues to this day is an area that we need to make sure that our communication from our providers, is timely and in a way that supports those particular areas. So I think our continued commitment to work with our individual organisations to make sure learning such as your case is taken through. I think also this would be really useful in terms of how we work with our wider board to increase our visibility within our respective organisations now that we're in the stages of living with COVID. Because I think we talk a lot here about the measures. This is a clear personal impact around what we're seeing within our integrated quality performance report. And I know a number of you have already visited Torbay's emergency department. So I think there's an element around how do we work collectively as a board to seek to understand and walk in shoes like yourselves, Mr. Fox, to understand how we can improve services going forward, and particularly, more importantly, work with our partner organisations. And I'm sure Liz will talk a little bit about the provider collaboratives role in sharing best practice and making sure that examples like yourself will never get things right 100% of the time, but become a less frequent occurrence.
Thank you. I'm also keen to bring Liz Davenport in, who leads for the Provider Collaborative.
Hello, Mr. Cox. My name's Liz Davenport. I'm the Chief Executive in Torbay and South Devon Foundation Trust, and also, as Sarah has said, I'm part of the Acute Provider Collaborative, and I want to add my apologies. That is a truly horrible experience, and I think you've spoken about the fear as well as the discomfort that's experienced waiting. And I think it's a timely reminder for us as a board about the impact of all flow through our hospital on the people who receive care. And it's one of my fears is that we start normalising waiting when we see the pictures of ambulances, we hear the stories of people in our emergency department, and it is not acceptable, and it's not something that we should accept for our public. I think the work that Darren has talked about is really important in the short term, is how do we make sure our pathways are as efficient, as effective as possible, and that we communicate to patients in every step of that journey and escalate when we're not delivering the standard of care that we aspire to. And none of that seems to have happened effectively in this case. And it's really positive to hear the work that Darren's already instigated in terms of improving the pathway. But I think there is a wider issue for us, which we're beginning to wrestle with as part of the Acute Provider Collaborative, which is how are we going to ensure that we're delivering sustainable services for our people in the longer term, both looking at the kind of clinical safety of our services, the workforce sustainability, and how we do that by getting best value for every pound that we spend. And we've got a paper a bit later on in the agenda today that talks to some of the things that we need to do so that we can improve the sustainability of our services and take courage in redesigning some of the ways in which we work so that people, Mr. Cox, and people who use our services in the future do not have that experience, and we need to hold those stories in mind. So thank you for sharing it with us today. Our commitment has to be to take that learning and use it as a key driver for the changes to implement. Thank you.
Mr. Cox, I'd like to bring in our Chief Medical Officer, Nigel Aitchison, because I think there are some points here about whether you needed to be within that department, what else could have been done. So, Nigel, can I ask you to come in?
Thanks, Chair, and thanks, Mr. Cox, for sharing that terrible experience you had, which is still clearly leaving impacts upon you after the event. So I'd like to add to all of my colleagues and apologise to you, because that is absolutely not the experience that we would want for any of the people of Devon, including ourselves. So sorry for that. I'd like to build on what both Darren and Liz have said, because I think in the story that you've told, I think hopefully for us in the board, there are opportunities that we're seeking to build upon to try and dramatically reduce the chance of this happening to either you or other people again in the future. So one of the areas of work that we're building on is our NHS 111 access for people who require support, such as the support that you required at the time, to help the people of Devon help them navigate through the system to get to the right place for the right treatment at the right time. But linked to that is some help and support for our providers right across our system, so that they too will know how to support people, with particular issues such as yours to get to that right place at the right time for the right treatment. And as Darren said, one of the really encouraging things is the technology that you've been able to access that hopefully worked very well for you in terms of the shock that it gave you to, once you had that cardiac arrest, and the link then to the monitoring. But actually what we hope then to be able to do is to make that pathway much better, so that when you get that message after an event such as that you've had, that it will then help us direct you to the right place where there will be the appropriate support to find out exactly why that was triggered and what was going on for you. So I think that there are some real opportunities, and we'd really like to thank you for the story that you've shared with us. There are some opportunities for us to really galvanise that work that we're already embarking upon, that you've heard about, to really take that forward as quickly as possible. But also, I think it reminds us that we are whole. We are not just our implantable cardiac device. We are people. And the impact that psychological distress that was caused by your experience has caused. And we also need to take account of that in support of people going forward too. So I do not underestimate how difficult it is to share a story such as the one that you shared with us, and would really like to thank you for doing so, and hope that we will be able to refer back to the story you told us as we're building that better future for the people of Devon.
And thank you. Can I ask, Mr. Cox, are there any questions that you would like to ask of any members of the board here today?
No, I mean, what the three people have said so far, sort of makes a lot of sense to me, and there's no questions yet. No.
Thank you. Can I ask, do any other colleagues here today have any questions for Mr. Cox, or any further comments that they would like to make? Well, perhaps sorry, yes, Sarah Lee.
Can I just ask you, you mentioned that you do need some psychological support after what you've been through. Are you receiving the psychological support that you feel that you need?
Yeah, weirdly, about 2 weeks after I came out of hospital, I got a circular saying about a arrhythmia support group which was being held, inviting me to it, which I went to at the Barnsley Rugby Club, and I was just astounded at the number of people that were there, families and people with pacemakers and implanted cardiac devices. And the talk was about anxiety. And I've had lots of things over my lifetime to do with my heart, but never, ever has there been any talk about anxiety, and you just get on with your life. So when this lady, who was incredible, got up and spoke to everybody, it was just enlightening that I actually felt I ticked every box that she talked about. And I think that was the first time I realised that the impact mentally that I'd suffered, if that's the right word. And I followed that up by calling TalkWorks, they're called, and spoke to them about therapy and explaining what had happened to me, etc. And I'm now doing this online therapy called Silverworks, which I've only just got the downloaded the course with. I think it lasts about 8 weeks or something, but it actually feels like a very positive thing, confronting all those fears and anxieties, and I mean, every emotion you could imagine. Maybe I'm a sort of weak person, but it's hard to do it, to talk about it. And I guess, we hear so much about mental health right now, so it's a bit more, it's easier to talk about because you don't feel it's sort of something you're just keeping to yourself, But I must say, with friends and family, I mean, I feel like I shouldn't say anything to sort of, I don't want it to be my story forever. Do you understand? It's
yeah.
So yeah.
I'm really pleased that you found that, and I'm really pleased that you found that, and I'm really pleased that what's interesting is you found it through peer support, didn't you? You found it through other people in your situation. Yes. So would that have been something that would have been useful earlier in your journey, perhaps if you were aware of the support groups that were available to you earlier on?
I think 35 years ago, when I had a replacement aortic valve, it would have been quite useful. But you're younger, you're doing your things in the world, so you move on. So I think it's now that I'm sort of 70 years old, I suddenly, there's a lot of thinking back, and that's what keeps me awake at night. Could things have been different from this point? So yeah, I think the opportunity to talk to people beyond your, immediate medical thing and the mental thing is a really good thing.
Thank you for reiterating that point about the importance of peer support. So thank you very much, and perhaps something we should also follow up. The other point that's very striking to me is your experience within the department itself. I mean, clearly the underlying fundamental problem is the length of time it took, but also the physical conditions within the department, not having access to drinks. And I wonder, Darren, whether in following this up, that's something that we can also assure Mr. Cox that we'll consider.
Yeah, no, absolutely. And there is a framework or a programme called Patient Experience and Environmental Assessments. So we have people like yourself, Mr. Cox, that go into hospital environments with those eyes to look around actually how would you access drinks, how would you access food, and particularly on particular wards. So again, what I will do, I will pick this up with my chief nursing colleagues across the providers to make sure that, as again we've moved out of the pandemic stages, that ultimately what we call the PEAT assessments are back up and running. Equally, one of the things I will also be talking to in terms of my CNO colleagues is particularly things like vending machines and things that clearly, as part of hotel services, I would normally expect at least 3 times a day sort of checks around those particular areas to think that if those areas are flagged, that those should be addressed through normal hotel services. So again, there are probably more questions that you've posed than I can give answers at the moment, but ultimately in terms of steps forward, I think clearly things like access to hydration in waiting rooms is a fundamental area that we've got to get right, and one that can be relatively easily addressed as well.
Thank you. Well, very grateful again to you, Mr. Cox, for the time you've given us today. And what I'd like to do is commit to you that we'll get back to you and speak to you again to actually give you some follow-up on the work that's being done following you taking the trouble to come and share your experience with us today. So again, thank you very much for joining us.
Thanks for the opportunity. Thank you.
Thank you.
Thank you very much.
Bye-bye.
So could I ask that goes as an action for us to make sure that we've had some follow-up? Can I ask, Liz, how long do you think it's likely to take, Liz, for us to be able to be in a position to get back to Mr. Cox with the work that you're doing? Would that be 2 months as an action?
Yeah.
Thank you. So that will be with Liz.
A range of personal. Yeah.
Yes.
Well, I think there's some actions as well, just in terms of following up directly with the hospital. So to some extent, particularly, and we've talked a bit before, haven't we, about how we help support some those extra sort of pairs of eyes and some of those basic things, as Darren says. But actually, I'm sure Sean, who's the chair of RDUH, would also be quite interested to hear the story, or not the story, but to hear the experience of Mr. Cox. So we just need to ensure that we've got that cross-pollination, so to speak, because it's really powerful. We don't want people to have to keep repeating the same thing. And also the other thing which might come up is about, he didn't mention it, but he didn't really have very satisfactory response to his complaints. That's a theme that we'll need to be picking up as part of our quality work.
Right. Judy.
I just think there's one really key thing in there, and I wonder if it's a question we should ask of all our A&E departments. So when a new innovative digital-based treatment is introduced, why did they tell him to go to the A&E when he needed to come in for review? And I know it's a clinical pathway question, but I wonder how much that is happening, and whether it's worth just asking that question of everyone. The whole point would be not to do that.
Not to sit in ED. I know Liz wants to respond, and also Darren.
So Thank you. I do think there is the points around ensuring that the basic safety standards in the emergency department are being applied consistently, recognising that people are waiting far longer than we would expect people to wait in department. And I certainly will be talking to my colleagues about the level of assurance we currently have around those standards. There's a more fundamental issue for me about that, which was about communication. Yeah. And I think if we had spent time explaining to Mr. Cox at every step of the journey what was happening, and also escalating internally in the organisation when we weren't able to meet those needs, we might have not had the story that we've heard today. So there's some fundamentals for me about how are we communicating with our patients when they're waiting longer than they should do, and how are we escalating, and I think we should take that as an action.
And so you'll look at his experience and report back to us and the correspondence to him. And Hisham wants to come in, and Darren, but we haven't heard from Hisham yet. So
thank you, Chair. I just want to follow on from what Judy and Liz said. A lot of departments, particularly with complex medical problems like ICDs and the like, actually have a contact person for the patient to contact if they're running into problems after the immediate emergency situation, where they can contact that person and they would then take up they will give them the appropriate advice, etc., and put them with the right people, like coming to cardiology, we'll sort this out for you, etc. And that would take a lot of the anxiety that Mr. Cox has suffered from. Thank you.
Thank you, Darren.
I was actually just going to build on Hisham's comments. I think one of the elements here is, again, probably one that we can pick up as well, is about the 7-day service debate here, because I think a small district general hospital, a pacemaker check or an ICD check is from what I can understand, is exactly what Mr. Cox needed. But actually, being in a small DGH, it sounds like this happened on a Friday, and actually you then had didn't have a 7-day service. So I think again it's about the collaborative around, well, actually, if that wasn't available in North Devon, where would the cardiology support would be to help the ED, being a very generalist department. I think it's that wider debate around what is our approach to 7-day services as a Devon system.
Thank you. Yes.
Sure. I'd just like to give a little bit of balance to this, because Sarah Lou and I went and looked at Torbay at the end of the last meeting. And I have to say, Liz, please congratulate all your staff. They are doing a fantastic job in very, very difficult circumstances. This case, me, should never have gone anywhere near an emergency department. And that's a fundamental issue. And we need to look at all of the things that are getting directed through the one acute front door, because they are balancing all sorts of things. And that department has changed how they function 6 times through COVID, and are doing an absolutely amazing job in a state that is about to be better, but has not really been adequate. So Mr. Cox's case, I think, is really, really important in how we direct people through a place. But, I think a lot of the emergency departments are doing fantastic work as well.
Thank you for that really important point as well. I'm keen that we now move on to the next item on the agenda, colleagues, and that is the Chair's report and the Chief Executive's report. And I just want to flag up a couple of areas from my report. First is to congratulate James McInnes, who joins us online today, who has now become the substantive chair of the One Devon Partnership. Thank you very much, James, unanimously approved by the board. The second area I'd just like to pull out was the comments I made about industrial action and the impact of that. And I shall bring Paul Renshaw in shortly as well, just to say that as you will be aware, the Royal College of Nursing has balloted in favour of industrial action, and that affects all trusts within the integrated care board area, the NHS Devon board area, and that the GMB, Unite, Unison, the Chartered Society of Physiotherapists and the Royal College of Midwives are in the process of balloting, and that the BMA have indicated that they intend to do so in January. But this is also in the context of workforce teaching unions and across local authorities, which will also undoubtedly have major impacts across the NHS as well. I'm told that by Monday we should know the dates for the proposed industrial action, and just to update colleagues that there are processes in place at the moment to sort of test out what our response would be in the event of industrial action. But as I say, I'm keen to bring Paul Renshaw in here as well. So Paul, were there anything that you wanted to add?
I mean, just to say that we're in the middle of a sort of 3-day sort of EPR sort of exercise called Operation Arctic, where we're sort of having a thorough test of all of our processes and procedures in the event of strike action goes ahead. The important thing that is ongoing at the moment is the question of exemptions from strike action, i.e. the derogations. So the kind of commitment that, you know, emergency services wouldn't be effective. And I guess it's the definition of what constitutes an emergency that we're just working through at the moment. I think it's fair to say the RCN aren't still in a consistent place on that. So those discussions are ongoing, and I know Darren's meeting with CNO colleagues this evening to look to sort of get consistency across the system on that particular issue. I think it's fair to say that in terms of the RCN ballot, all NHS organisations cleared the threshold, i.e. more than 50% turnout. So the kind of range was between 53 and 60. The particularly sort of startling sort of stats within that is the percentage of people saying yes to action. So anything between 88 to 91% of those who did turn out said yes, they voted in favour of action, which is exceptionally strong. The Health Secretary met with the RCN yesterday. No information, formal or otherwise, of that, and clearly we all hope that there's some resolution to this for everyone's sake before any action actually starts. So we've agreed a set of consistent communications across the system. And like Sarah said, at the latest Monday next week is when we'll find out those dates. Those dates would get them 7 days notice of action taking place beyond that. So that's as much as I can give at a particular point in time. The Arctic work, I should just say, is also focused on the potential of strike action within other sectors. So in the event that teachers go on strike, clearly there's a knock-on effect to all workplaces, including the NHS workplaces, in terms of staff not coming to work because they're there and their children are at home. So there's a lot to think about.
Thank you very much. Jane, for your Chief Executive's report.
Okay, thank you. So, as always, the ink is never dry before other things happen. So I wasn't necessarily going to pick up anything particular in the report, but I suppose I wanted just to flag a couple of things. With Steve Barclay now as our Secretary of State back into that role, quite a lot of work happening, particularly in relation to the financial settlement, and we are expecting obviously some announcements about that tomorrow, and also going into next week. So I think it's fair to say the new ministerial team feedback I've had is working very closely with colleagues in the Department of Health, but actually also with Amanda Pritchard and her team. Quite a big focus on primary care, and as well as the ambulance waits, and also to some extent how we use the data that we have to ensure that we're working as collectively as possible across health and social care. I understand that we will also have an announcement either tomorrow or later in relation to the allocation of this some extra resource, which was highlighted a while ago, I think 500 million across the country, which will be my understanding, and Tracy might know more, and proportioned out on a population basis, but split between ICBs and local authorities. So we will obviously need to work closely about how best to get the sort of impact that we need for that. And then also just to add, the other thing is we've been doing quite a lot of work in relation to winter planning in terms of getting our system control team up and running, and that is from, well, in fact, to some extent, we've had the foundations of that in place for over a year, but we have got some extra requirements to put in place from the 1st of December. So obviously now working with Anthony on that and trying to ensure we've got the right clinical and managerial cover over the sort of weekends and out of hours as much as in hours, which is not without its challenge, because also we need to ensure that we have our emergency preparedness team also available to any incidences, which of course the industrial action is likely to give us a need to coordinate. So they were the key things I was going to pick out.
Thank you very much. Does anyone have any pressing points they want to make to Jane? No? Great. We're going to come on now. So those are both for noting. To the assurance and system oversight section of today's board meeting. I'm coming on to the item which is going to be led by John Finn on the performance framework and elective winter care plan. And just so that we're clear in advance, what we're being asked to do is to endorse the self-certification process. So I'll come back to check that the board is content to do that afterwards. So John, over to you.
Okay, if I could just give a brief summary of this, actually, which will help that question over the board. On the 25th of October, we received a letter on next steps on elective care for Tier 1 and Tier 2 from James Mackey and Dame Callie Palmer. It requested that the Devon system undertake a board self-certification process, which was signed off by trust chairs and CEOs, an unusual process, I'd have to say. The ask was to submit directly to NHSE, as it's the trusts that are in the tier system, not the system. However, in line with other work we do, e.g. the National Tier 1 programme, we've worked with NHS England to deliver this ask with the ICB coordinating, and we've been gaining the assurance and submitting to region. I think it's really important for the board to understand that there's no areas in this letter which are not covered in either the Plan Care programme, the diagnostic programme or the cancer plans. They may not be all in the IQPR, but the performance in those areas is challenged in the deep dives, e.g. elective and cancer recently at the Quality and Performance Committee, and they reported via the subcommittees. So I can confirm that all trusts have signed and returned that to me on the 11th actually, and that was submitted to the region. There are some areas that need further focus via our ICB performance meetings and the Tier 1 process, but these were fully understood before this process. So just an example, in terms of 78 weeks, the 3 trusts initially in April 22 did not submit a compliant plan in this area actually, and that's been managed through the tier process. In terms of 62 days, UHP and RDU make a significant process and will move out of Tier 1 of cancer. That paperwork is going through the region at the moment. In terms of cancer, the prostate pathway, lower GI and skin are challenging across England actually, but we are working well with the Cancer Alliance and ICB on the performance improvement, particularly the prostate pathway, which is the most challenging. I think at last board I did say that productivity needs more focus, and certainly theatre productivity needs a greater focus in this actually. So I said that'll be a key part of our ongoing governance. In terms of diagnostic delivery against the time-bound targets, it's processing well, but delivery of 120% against 1920 remains challenging. It mentions the Super September. Now, this was not all reported to boards. However, this was a system piece of work led by my team actually. Each trust has a clear plan that's managed through the system outpatient programme. So, very brief summary. Thank you.
Thank you. Does anyone have any questions for John on this? So you're reassuring us that all of the trusts have signed up
100%.
to the letter on time, so that's good to hear. Yeah. So as I say, we're being asked to endorse. Sorry, here we are, Sheena.
Yeah, it relates to both Sarah's report and what John's been talking about in terms of the sort of social care issue and relieving winter pressures. I mean, as a system as a whole, we all know that it's the problems of discharge are one of the real issues creating the kind of barriers to the smooth flow. And I it's just kind of increasingly come into my head that Are we open to sort of alternative forms of provision for that step down service? You know, in that it strikes me as that, you know, if I had the kind of power and money to put things into place quickly, I'd possibly try to look at setting up a hybrid between the kind of old municipal care home and the kind of community hospital bed, you know, which doesn't have to be fitted out like a hospital room, doesn't need to have the same staff, you know, could potentially provide us with
the problems of discharge are one of the real issues.
And so at the moment, I'm lacking the detail in quite a lot of the things, you know, in terms of, you know, we've got the plans. I don't know what the plans are.
It's just kind of increasingly coming to my head.
Are we looking out of the box in terms of what we call the social care issue, but is actually a sort of discharge issue, and it's a little bit more complicated than simply social care, isn't it?
Jane, would you like to respond to that?
Well, it's a slightly large question, but I suppose what I can do is, because of course there is a lot of detail, and but I can reassure you that we are looking at every possible option and working very closely with our voluntary sector organisations as well, to because actually the fundamental thing that limits this is workforce, and to some extent, I mean, we are. Again, Tracy might want to come in, because in fact, I think we have done a lot of work to develop the discharge to assess, or the care hotel approach, which has been very successful and actually is also helping to bridge some of the challenge across into Cornwall as well. I think certainly, ultimately, we do want people to be returning to home as much as possible. So that's intermediate care and the support in different ways is also part of the plan. And I know certainly we've been talking with local authority colleagues about ensuring that we've got the right model of care. And certainly with any extra resource that does come through, I think from my perspective, there's an opportunity to do another bit of stock take just to answer again your question, Sheena, which is one I consider about every day about, you know, is there, what more can we do? I can see Tracy was leaning forward in an active way and
leaning forward into the room, into the discussion. So I think, Sheena, it is clearly a massive issue, because actually the question you're asking is about the whole system and how the whole system operates. And appreciate this is, you know, whenever there's an assurance statement where people quite literally sign in blood to say things are going to happen, then we want the assurance that everything is going to happen to make that the case. And I suppose for me, one of the roles for us as a board is we get lots and lots of papers, but actually that helicopter view of the connection of the system together is something that if we don't provide it as a board and check that. So I think your question is really, really valid. And it is about ensuring we're seeing that whole picture. And then, in fact, even from the patient experience today, that sense of a system where flow doesn't work, people are going to places they don't need to go, anxiety about not even moving from a chair in case you're called or missed, as well as those fundamental issues about workforce, both inside the health part of the system, but actually more generally within the care system. So I think there's something for me which is quite incumbent on us as a board to keep that system in our minds at all times, and the interaction that system plays for us. And one part of the system, I think there's a really the narrative and the sense of the problems in the care sector, I think, are now really coming to the fore. What we'll see is inevitably that manifesting itself at the front door of ED. And so the in many ways, the danger is we're focusing on the front door of ED, and we are not looking at where actually we are quite literally whack-a-moling the problems back in the other parts of the system. So system pressures that we experience in other parts of the system have a massive impact. So I'm not sure I've answered the question, Sheena. It's just a stream of consciousness about what I think the board's role is in really, really understanding those key elements of the system that impact on another part of the system. What I will say just very briefly, though, Sarah, if I may, just in terms of what the Chancellor may announce tomorrow in terms of the funding,
and the fact that we have still not got a clear picture of how social care is going to be taken forward in this country. And, you know, when you look at what, and I know mentioned in the papers, when you look at what John Hart has said, you look at what Linda Taylor has said, you look at where we are. We have put last week on the table in Plymouth, our budget's a £201 million net budget. We have £26.5 million of savings on the table, and we have to find another 11.5 million just to be solvent by March. That goes some, but we have to do it. We have no choice. We have to do it. And Devon is exactly the same. Torbay is in the same situation. So those factors influence how we work as a system and how we pull this together. So I just thought I'd just mention how grim it is in those parts of the system as well. Thank you very much, Tracy. And there are some examples of innovation. For example, as Jane has mentioned, the care hotels. But I think that we do, as a board, also have to look at the quality and what that delivers. And I think that is part of our role as a whole system. I'm keen to bring Liz, and I know Simon wants to comment as well, and then I'll come back to you, Sheena.
Thank you, Sarah. And my point's not dissimilar to Tracy's, really, because I think sometimes we talk about discharge and we assume that it's one problem, i.e. the capacity that's available in the community. And clearly that is an issue, but it's not the only issue. And I think there is just something about how we seek to optimise our total capacity and make sure that we're making that as efficient as possible, because the funding challenges aren't just for social care, they're across the health system as well, where we're spending more money. And I think we need to hold ourselves to account as a board to make sure that we're optimising every little bit of our pathway, including the out-of-hospital care offer that reduces the likelihood of people coming into hospital, and making sure our pathways in hospital work in a really effective way. We heard from Mr. Cox that a really extreme example of not getting that right, as well as making sure that we're working collectively to look at the range of out-of-hospital options at discharge. And I do think there's lots of really great work going on. Actually, there's real innovation in that space, and there's real around holding to us account as a system to get the best out of it. But we've still got further work to do. Thank you, Simon.
Yeah, so we've made some. So yes, Sheena, we are looking at all kinds of different options. At the minute, bedded discharges are not the particular issue. It's home first with what we call pathway 1, so domiciliary care support. But we've seen really good reductions in Plymouth, Exeter and Torbay over the last week or so, and we're actually the lowest we've been for quite some time in terms of our no criteria to reside or full term, but that is the national term. I know Frank said some very nice things about Torbay, but Torbay are currently the best performing in the region for weekend discharges. More to do elsewhere. But my point was, there is more to do in complex discharges, pathways, what we call pathways 1 to 3. But that is a very, very small element of the overall discharges that are required every day. Simple discharges, pathway 0s, we need to make sure that we are getting 80% out by 5 o'clock. So I can say, even though I'm sat next to Liz, we are not doing that in any of our 4 hospitals at the moment. And the reason they are simple discharges is because they need no onward care. So they should be easier for us to control. And just for assurance of the board, I get a 2-hourly automated report from Plymouth about what their predicted discharges on pathway 0 are and how they are getting on. I won't tell you today's figures because I'd rather tell you something more positive.
Thank you. Is there anything you wanted to follow up with, Sheena, or has that answered your question?
No, it has, and it is reassuring to know there's a lot of innovation going on. I just feel that, I mean, you know, we're already under intense pressure, and I'm sort of, you know, it's naturally very, you know, alarming to think about what we're going to be like in January and February. So, you know, in response to your question about quality, of course, we should never compromise quality, but it may mean organising services in a slightly different way that we think is the norm. And I mean, the precedent would be Nightingale in terms of providing something very, very different, because you simply have to. So I just want to know that even things which don't really seem particularly acceptable might be on the table because they have to be.
Thank you. And a lot of our bed equivalents are still yet to come on stream. I think that's correct, isn't it?
January, February, when
yes,
should be seeing peaks, more capacity in place.
Thank you. So can I just check for the minutes, is the board happy to endorse the self-certification process? Thank you. So we're going to come on next to the item which Darren is leading on the review of the findings of the East Kent maternity and maternity and neonatal services report.
Thanks, Chair. And this is building on the conversations that we've already had at the Quality Committee earlier this month. And I think it's fair to say, as a local maternity neonatal system, and I think as I can speak on behalf of the chair of the Quality Group, I think that we're continue to be saddened by the reports that continue to come out nationally regarding failures in maternity care across the system. And I think this report has some very significant impact and builds on the wider recognition of the poor care. And I think it builds on the Ockenden reports, Ockenden 1 and Ockenden 2. But ultimately, the 4 key themes worryingly are similar key themes around early recognition of poor performance, around concerns around compassionate care, which as a nurse, really cuts to the core in terms of, that is fundamental. The ongoing challenges around team working, and then the recognising around the honesty around challenge. So I think, my worry and hearing the report is that these are continuous as a theme of earlier reports. So I think as an ICB and having the governance within the local maternity neonatal system and through to the Quality Committee and obviously on through to boards, that we need to really focus on signals. So on the early elements, I think what we've heard time and time again, we talk very eloquently here about, and even the IQPR around serious incidents. But for every serious incident, there are a number of low level harm or no harm near misses. So we really need to make sure that we are working as a system and understanding the early signals in terms of where we can make sure that as a collection that we address those areas. So within the report, there are 5 recommendations, and ultimately Devon's response to those collectively through the local maternity neonatal system is that we have a well-established quality and safety group, which is around maternity systems. We have now got a dedicated quality and safety midwife that works at system level with our HOMs across the 4 maternity units. We need to increase the obstetric challenge in there. And I know Nigel's talked eloquently at the board before around those particular challenges, but ultimately we do need to make sure that is balanced coming through. Ultimately, we will continue for the local maternity neonatal system around the assurance and particularly around the quality governance that we have with our heads of midwifery. We have just recently completed with our NHS England regional colleagues insight visits. So we have visited all 4 of our sites. I think, we have identified some very good practice in those areas, but equally we've identified some areas of improvement. And the beauty of that, we can then share that improvement across the entire Devon system. So where we are seeing good practice in Plymouth, we can then share that across the other 3 units, and vice versa. Where we're seeing good practice in South Devon, we can share. So I think that we are building this on some good basis. I think from a reassurance point of view to the board, I think those insight visits have focused on a number of the areas that this report has elements of. Some of the areas that are more difficult to truly measure is around clinical behaviours and those team working elements. And I think what we're doing is we are knowing that a number of maternity units are going back around culture surveys that they've done previously. So we'll start to see those through the local maternity neonatal system. But more importantly, our focus will be around using the national maternity data to monitor safety at the lower level. And one thing before I open to questions is I think, although this and the Ockenden reports are very much focused on maternity systems, are very much focused on team working there, I do think we have to ask ourselves, that if we looked at a cardiology team, or if we looked at an ED team, or we looked at a surgical team, we probably need to ask the same questions about team working and some of those cultural elements, because I think this is a symptom that we're seeing and has been very acute and long-standing within maternity services. But I think some of the systems that we're seeing, particularly around never events, some of the harm events we're seeing at the moment, there are probably similar learnings that we need to take into those areas as well.
Thank you very much, Darren. And I can see that Liz Davenport and Nigel Aitchison, yes, thank you very much. And Kevin Orford would like to come in. So Liz, would you like to go first?
Thank you, Darren. I have read the full report and it is a really challenging read because I think it speaks to the real experience of families who have some of the worst outcomes that we might expect. And I think we have to hear that and feel it because I think that just keeps us connected with it. Yeah. One of my worries is that not only are we seeing repeated stories, but what is that doing to give confidence to people who are using our services, and we have to pay attention to it. But I wanted to particularly focus on Darren's last comment, which is around culture, because there's a very strong theme here. And certainly from my board's perspective, the test we are asking ourselves is how would we know that we have a culture which is supporting compassionate care and safe care. And we're focusing here on maternity, and the insight visit was a really helpful opportunity to reflect on what we do and the improvements that we could make. But I think we have to open our mind to think beyond maternity services, to think about how we check that the culture is the right culture to deliver the quality of care that we aspire to as a board. And certainly we've commissioned something internally in my trust, but we might want to pay attention to that as a board more generally.
Thank you. And Nigel Aitchison would like to come in.
Yeah, thank you. Just to build on that, so I think I said before, so I inspected East Kent and Morecambe Bay and Shrewsbury and Telford in maternity. But the point that Darren makes about more broad issues and problems is absolutely on the money. And the issue here is, and Bill Kirkup, who did the East Kent report this time, wrote the Morecambe Bay report back in 2015. And the issue that he raised was that, of course, there are individual responsibilities and accountabilities in each of these services. But as Liz says, it's for the board to pick up any deviation from the standards you expect. You will not do this by just sitting back and waiting for incident reports. As Darren said, you need to be proactive. So we need to encourage that proactivity through the work that we do in the business that Darren and colleagues did through the LMNS. You will only pick this up by putting your feet on the ground, talking to people and looking and poking. The other bit that is really, really key is that over the years, governance processes inside trusts have become really cumbersome. And as people understood them less and less, they just added more bits to them. And so the connection between the boards and those frontline services have become really blurry. And the pressures that people are under, they're often buffed and polished every bit of those layers that they go up. So by the time a board sees it, the boards are reassured, not assured, by all sorts of shiny messaging. And cannot overemphasize the need for us all, at whatever level we are, to be going and seeing and looking and asking and checking. And it is about those cultures that we need to across the system. And as Dan said, unfortunately, this will be happening not only in every trust, but in multiple departments in trusts. And there's no escaping that. And as Paul's described in terms of the sense of feeling, whatever that feeling is expressed in the votes for industrial action, those behaviours will leak out, unfortunately, in people not having that compassion at all times, because there is something that's underpinning that that sense that they're not happy for somebody.
Thank you. I've got Kevin, Graham, Judy and Sheena wanting to come in, but I know Liz just quickly wants to respond very quickly to that.
On that final comment, I think there's something material there for boards around, so how do we assure ourselves and what is the evidence that we look to that gives us that assurance? Because I think that was a very clear message in this report, is people took the information that was in front of them. They actually denied some of the difficult stuff and didn't really seek the assurance and the evidence that backs that assurance. And I think that has to be a responsibility for us as a board.
Thank you. Kevin.
Yeah, thanks. I forget how many of these reports have been, I mean, you alluded to, common themes over time. I mean, I go back to 2004 and Kidderminster, and there's almost been one every couple of years since then. So there's a bit of a question around what are we going to do differently this time with the latest one, and when we get the Nottingham one in a year's time, are we going to be sat here again with another action plan? Which I don't expect answers to that directly down. There's but I want to just home in on another's alluding to. I mean, there's a bit of this which is about the providers, isn't there, and the trusts and the governance in the trusts and knowing what's happened there. And you honed in on what's the ICB role on this, which I just wanted to explore a bit, because you're talking about focusing on the signals of the national data set. The missing piece of jigsaw for me when I read this report, though. After the report came out a couple of weeks ago, I was just on social media reading what people were saying about it, and it's just loads of kind of real life parents and families experiences of this. And I just wonder how we capture that in real time, because in terms of signals of what's going on in the services, it's kind of that I want to know, what is it, as someone who's going through those services at the moment, what are they saying about it right now? What are their families saying about the experience? And have we got a way of bringing that into our early warning system at the ICB?
Yeah. Do you want to, and I'm happy to, and I'll probably add to your comments.
One of the things, there are a series of national patient experience surveys, and one of them is the National Maternity Patient Experience Survey, which each year tells us some of the themes that people have experienced. So one of the really common themes, and I would imagine it came out of that social media, was postnatal care and some of the deficiencies. So there is national level data that comes, but it's built from local provider level. So you can drill down to local provider level. So that's some of the work that the LMNS will have that Darren talked to. And we've got the Maternity Voices Partnerships who are key leads on that. So one of the things that, because we too produced a couple of reports on this, saying, and I've said it before more broadly, that people who are pregnant are not sick by and large, they are just pregnant. And therefore, having people as partners, the most important partners in their care, and that's the change that is beginning to happen through the interface with the Maternity Voices Partnerships, who are promoting this idea that people who use our maternity services are the best judges of the quality through the experience they have, and that's now baked in to the local maternity system. Now, I think that's the canary in the coal mine, and is a real beacon for how we need to do this right across the piece. The experience that Mr. Cox had would have been very, very different had he been genuinely viewed as a partner, a free partner in his care. And he was the expert in his care. He'd had this thing for years and years. So I think the work that Darren and colleagues are doing is really a spearhead for how we as a board will want to promote this idea that patients are partners in their care. And, with Lou on our board, as a true board member, changing the relationship with people who use services and having them help plan what good looks like.
Yeah, I'll just go with that because I think the Maternity Voice programme, or the partners in Devon, are exceptionally strong. Yeah, they are not shy in coming forward. They are an active member of our local maternity neonatal system. Each of them have a co-chair, so each of the maternities have an active chair that has regular meetings with the head of midwifery, but they come to the system meeting, and they are very present. They have boards within each of the maternity units. They have groups, etc. So, as you say, Nigel, they are the canary in the mine, and I think that is that's different. I think the data tells us one element, the insight visit tells us so that's the two-dimensional view. We've got the data, we can check that in an insight visit, but actually the lived experience through the maternity voice is absolutely probably is the three-dimensional view that we now have that we didn't have through any of those programmes. I need to think of my provider data only 2 years ago in North Devon. We did not have an active maternity voice, and I think you're looking at the chance where in North Devon, it would have been a different story if we had that active voice in there.
So what I'm hearing is we are systematically cited on that.
Yes.
ICB.
Yes,
that's great. Thank you.
Thank you for that. Graham Clark, who wanted to come in next.
So if I think about principles of good assurance processes, you have to have multiple pathways, don't you? Because if you have only one and there's a failure with it, then you're nowhere. And those need to be ongoing, not just as a one-off, as it were. So, of course, you can go in there at any point in time, but that's not good enough. So if we work to those principles, then what I'm seeing the recommendations here is may be sufficient. I don't know. It's a question. You've appointed a lead ops person and a lead midwife, and yet one of the things that the report points out was dysfunctionality between those professions and point failure. So I guess all I'm trying to get to is assurance that there are indeed multiple pathways clearly articulated that work that will provide us with the feed, so we don't end up back in the problem of a single point failure, especially around some individuals, whoever they are and however they may be. what's that crisp articulation of the multiple pathways?
So one of the things, so we did a series of inspections in places where some of the flags had flagged, and one of the findings was that triumvirate, so it's more than just the obstetrician and the lead midwife, it's also the service manager. And what we found in a number of those is that one or more of those posts was either there wasn't a post holder, or there were a series of interims in those positions. So it wasn't a coherent team of three. But the other piece that has happened and is happening again is they do a sort of a team cultural assessment. And so that will be one bit of information that boards can then see. And that self-assessment is for the team. It's not really, it's a general assessment. How are we working as a team this year? What are the things and areas that we think we need to focus on for next year, which then can garner support if necessary or resource if it's required. So there are objective ways of checking that those bits of the system that you're depending on at that service level are working. And as we said, one of the things that boards will have visibility of the composition of those teams. And we now know that if those teams are unstable, that, in other words, the relationships aren't working, that's a big risk, that's a big flag.
So I get that, but what's the alternative pathways that we would get feeds?
So we've got an extensive data set for maternity services, which is just being updated itself. So unfortunately, as we said, that tends to be a bit reactive. By the time you get a signal that that there are problems arising with poor outcomes, that's often a sign that things are too late. So that's why it needs to be supplemented with the sort of cultural survey advice, the checks that trusts do to make sure that colleagues are trained appropriately, and there's a bundle of training colleagues have to do, some of which is individual competency based, some of it is team based. There are set scenario based training simulations that have to be done. So making sure those are all done, and then adding to that the voice of people who use services. Actually, that's quite a good.
Yeah, I would say for maternity, it's probably the area where you have the most channels, both in terms of qualitative and quantitative. And I think there's learning to take from other areas. And I think the other bit for me is there is also a requirement of all of the provider boards to have a non-exec director champion for maternity as well. So again, I think there are probably 6 to 7 channels of element which will all triangulate, and as you say, one will start to pop up and you then start to check that against the others. So I think looking at, particularly with the local potentially LMNS, we are looking much more. So actually you've got 7 channels of information coming through, and we can check and challenge them.
It's just perhaps to add to that, Graham, at a sort of a tier above that, at regional and national level, all the regulatory bits of the system now come together on a monthly basis to share the information that they have. So there's an additional piece of almost flag that would say, actually, do you know what, we need to go and have a bit of a closer look. So that there's an additional tiering above that as well.
Right, now I'm conscious of time. We've got 4 colleagues who'd like to come in, so I'm going to take them in pairs. So I'm going to ask Judy Hargaden and Sheena Summers to come in next, and then have a response to that, and then Frank O'Kelly and Sarah Lou Glover. So Judy, would you like to go next?
I just wanted to say I'm not sure that these recommendations, we're being asked to endorse the recommendations, but actually all the recommendations are for actions by other organisations. I found when I got to the end of it, and much of this has now been answered today, do we have these problems? How do we know that we do or we don't? And what are we doing about them? And it's clear there is a lot going on. And I would like to ask that we have a more explicit report about what we are doing as a system about those recommendations, rather than that we are endorsing somebody else's report, because they're not mostly actions.
Although, of course, we're as a board being asked to endorse the nationally what the report. But you're quite right in terms of what we want to hear. We want the assurance that we are acting on this across our system.
Yes,
so
and that would be
that's something going to be. But we're actually endorsing the recommendations within the national report. Is what we're being asked to do. But we can change that to saying that
I think that's floppy nationally.
Yes. Okay.
Sorry to say that public. But yeah, if we could have something come back that gave us a bit more
assurance.
What people have been telling us today, which is clearly quite a lot going on, to make sure we're handling this issue.
Yes, so we can return to this. Sheena.
Yes, I've got two questions, both relating actually to the boundaries of the review. So I think in the Ockham report itself, there's quite a strong emphasis on sort of serious clinical events, whereas sort of maternity care is broader than those sort of never happen events, you know, and I mean, one of the things I may be wrong, but I noticed from my own experience of my many maternity adventures compared to my friends nowadays is the difference in the postnatal care support that women are having. So you know, I would have been visited by a midwife, a health visitor. The midwife certainly quite a lot in the first 10 days and things like that. You know, that seems to be really different now. And that worries me because it is a vulnerable time, particularly for first time mothers who need quite a lot of support and reassurance. And that can affect the subsequent relationship and confidence in parenting and things like that. So I'm just slightly worried that we're focusing on the serious clinical stuff and not the kind of wider support, and is that part of the review as well? My second question is also because obviously, I mean, I think it's quite right that the Ockham reviews focus very much on families and their family experiences, but I'm also conscious of staff in terms of workforce stresses, but also some of the really difficult challenges that they can have. And are we supporting our staff adequately on things like, you know, the trend, and I don't know if it's been reversed recently, but the trend towards free birthing, which really places midwives in a really difficult position because you're then sort of, well, I'm limited with how much I can, you know, you might be making decisions which I think are clinically dangerous for you, but I'm limited in how much I can really, it's about the boundaries of this review. I think it's a really complicated area, and I worry that we focus on the very tight clinical aspects where there's something a bit broader going on.
Thank you.
Shall I come back to those?
Respond, please.
Yeah, absolutely. Thanks, Chair. So I think you're absolutely right in terms of Judy's challenge. So I think, yeah, there is, so what? My proposal would be that we should really have those dialogues through the quality group to bring the local maternity up to the quality group, and obviously then through to boards that route, so we can have that detail, and actually then we can bring that assurance through the, you know, the governance routes. And in terms of Sheena's two comments, so I think, you know, the workforce one I'll answer first, because I think you hit an absolute crux here that we have focused very much on this from a family perspective, which is absolutely right thing to do. But the psychological impact that these reports have had on our maternity teams, you know, ultimately, and the public confidence in our maternity teams, you know, is one that we should not underestimate. And that's a lot of the conversation we're having with our heads of midwifery around what's the wider support mechanisms, what, you know, how, because actually, you know, I'm not a midwife and I sit and read the report, and, you know, it's a really hard read. And you think, if I'm, you know, a head of midwifery or I'm a midwife reading this report, yeah, this is my profession, you know, that has to be really, really hard. So absolutely. And I suppose to give you some assurance, so the national reports are the national reports, obviously the scope is, you know, is nationally defined. For me, you know, when we look at the data and look at the metrics, and particularly moving away from the serious incident point of view, which is one of the Ockenden clear measures that we should not focus on, not say that they're not important, but ultimately it's the number of low-level near misses, no harms, which goes across the entire pathway, you know, antenatal, etc. And also the other element that particularly postnatal, which we need to be really clear around, is potentially then how that goes into the public health arena and health visitors. And then unfortunately, sadly, you know, the wider safeguarding challenges that we see, you know, in particularly potential bruising, non-accidental injuries in non-mobile babies and infants. So this is actually a much, from a learning at local LMNS point of view, it's much wider than the acuity of the hours around the birth. It's the whole pathway.
Thank you. Now I've got Frank O'Kelly and Sarah Lou Glover coming in, and then I think we're going to need to move to our finance section.
Thank you, Chair. I think it's really important that we set the culture and ask the right questions. I mean, it's been known for 20 years that caesarean sections are safer in certain circumstances than going through natural childbirth. So nationally, the people working in maternity departments have had the message that it's got to be natural, and actually that was going to lead to worse outcomes. So we have to be asking the staff to do the right things, otherwise they're going to get the sort of results that they've got. The other part of it, I think, is we really do need to develop the culture where formal complaints are taken seriously. I mean, Jane's alluded to it, but I see the responses from a sort of patient's perspective. And if I'm really brutally honest, I think the culture at the moment is more about organisational justification of what comes in, as opposed to what most service industries do is look at a complaint and think, how on earth can we improve that? And they actually want the complaints to come in because it tells them what's going on. We don't, at the moment, I don't feel across any of the ICS, deal with formal complaints in the right way with the right attitude. It is more about self-protection and justification than it is about, you've made a really good point, we need to do something different.
Thank you, Frank, and bring Sarah Lou Glover.
Yeah, thanks. I 100% support what Frank has said. Actually, we have to look at how we can, not just how we can look at the things that go wrong and learn from them, but the things that we're doing right and what are we doing well. You know, what's happened with our patient beds in the last week. You know, that's brilliant. That's you know, no right to reside has gone right down. Well, what have we done differently? What's happened differently that we can learn from in those other beds as well? So with regards to this particular point, it's brilliant that the patient voice is being listened to. I just wonder how far it's going, and I'd like to challenge that. In fact, across all of this, with any of our services, how can we capture a patient's voice as soon as they leave that department? There has to be a better way of going. You know, almost like you've got at the end of your Tesco shop, you drop your coin in where, you know, maybe like, you know, it's almost like, right, you get so many stars for what you've done today. And was that the clinical side and the personal side, you know, the well-being side of you, was that taken into account as well? That's immediate. We could have that straight away, and I'm sure it's not complicated in order to do that. It's wonderful that there are surveys and that the patient voice is in there, but is it participation or is it co-production? Are they being brought in to have their say and then go away again and we learn from it, or are they co-producing the service with us? Because we'll only get a better service if they co-produce it with us, because we're saying they're the experts. So let's make sure that they are co-producing what they're doing. With regards to the workforce, we absolutely have to think about their mental health now. We can support them. And again, it's being innovative. It doesn't need to be expensive, but you know, how can we encourage some peer support or offer to that workforce so that they feel better about what they're doing and explain them. And from the postnatal side of things, absolutely, it's completely changed, Sheena. And again, you know, what we learned from Mr. Cox this morning, can we bring that again? Where when a young mum leaves the hospital or whichever situation she's in, are we making sure that she's got access and information around what she can access in the community, what she can do with all the different services that are available to her, thinking about that baby as a whole experience, you know, their mental health as well as how high they should grow, etc.
Well, thank you very much for those points. What I'm taking away from a number of the comments today is that could we put on the forward plan that we'll look at the quality of our response to feedback and to complaints, and maybe bring that as a specific issue for the main board to look at, and also take your point, Judy, about the so what happens next, and perhaps Hisham, that's that we take through your committee, and we'll put that on the action so that you're having a conversation about how we just take that forward. Would you be happy with that? Thank you. Right, now.
Sorry, just to add one.
Yeah.
So I think maternity voices are probably the most co-productive sort of group in country. So I if we haven't already included them as part of our discovery series, then I think we should.
Yeah.
And also to visit and work with them, because my experience, they are generally top notch in this, and very responsive to exactly as you've said, Sarah. So Sarah Lou, so I think we probably just need to make sure we've got a session where we can either bring them either to here or as part of our discovery, because hopefully they actually set the gold standard, I think, in that respect.
Yeah.
Well, that would be great if we put it as an action to bring them maternity voices to our discovery series, and then if they would like to come and be one of our patient experience feedback at the main board, we can put that on the board planner too. Thank you. I'm conscious of time, and we're coming next to the finance section, which is going to be led by Bill Shield. Thank you very much, Bill. Both the NHS Devon 6-month finance report, but also the wider ICS system 6-month finance report. So thank you very much, Bill.
Thank you, Chair. I think there's another item before that, the memorandum of understanding.
No, there was one item that we were going to have that was actually decided to bring back to another day, Bill. So it is you next.
Thank you.
But just before we go to that, as I say, we did have a bit of a discussion about whether we were endorsing, but I think we are saying that we're going to endorse the national report, but very much mindful, Judy, that this is about coming back with the so what at another time. Thank you.
Thank you. So good morning. This is the finance report for NHS Devon as at month 6. And one of the things I think we do need to consider going forward is the timeliness of the information that's presented to the board. So this information is now to some extent out of date and relates to a period of time where we've seen significant movement in the financial position between that and the current position. So going forward, I do think that one of the actions is to look at how more timely information can be presented to this board. The position that's presented at month 6 indicates that the organisation and the system remains at a position where it will forecast the planned deficit of £18 million, which was agreed at the commencement of this year. You will see from the report that is presented that there are significant risks within the financial position, and both this organisation and NHS providers continue to work together to look at how we can deliver the financial position. Also, from the risks and mitigations that are presented, you can see that the risk that's presented at this point in time, as at month 6, is that there is nil risk to the financial position. But I think we must be realistic that we have significant risks within the financial position, and there are significant pressures both in the ICB's financial position and that of each of the providers that works in the Devon system. As a consequence of that, I think the board should be apprised that there is a very real risk that we are dealing with in terms of the forecast outturn position. That is not to say that we are giving up on delivering the 18 million planned deficit position, but it does mean that those significant risks will require a concerted effort in order for us to deliver the position which has been agreed between ourselves and NHSE. Just recently, NHSE has produced a protocol which has to be gone through for any organisation or system which seeks to change its financial position. They've indicated that any organisation that changes that position too early in the fiscal year will be seen as one who has not delivered against their financial position. And equally, that any organisation that seeks to change their position in the final quarter will be deemed as one that has inadequate grip and control in terms of their position. So if there is a requirement, or if there is a need for us to change that forecast position, there's a very small window in order to do that. It's really important that if we consider that, either as a system or as individual organisations, that we understand that that doesn't mean that we forecast a position, then we breathe a sigh of relief, and then we can continue. The actions that will be put in place based on the protocol would mean that the ability of this organisation, or indeed any of the organisations in the system, to act autonomously and independently would be significantly curtailed. So a number of the actions which we are struggling to put in place across the system to achieve savings would automatically go in place anyway. The main difference would be they would not be our actions anymore. They would be those of the NHS Executive Regional Team. So it's a really sobering protocol, and one that I have discussed at length with each of the CFOs in provider organisations. Each of those will be discussing with their own boards what the impact of the requirements in the protocol would be, and as a consequence of that, how they might get their current financial position back on track to obviate the need to go through this formal process. Having said that, the position that's reported here does show, I think, in terms of the financial position, while there are a number of unforeseen circumstances that have occurred during the course of this year, and they have required non-recurring funding to be used to offset those, the fundamental problem of the financial position within NHS Devon and its constituent organisations is a failure to deliver cost improvement plans. That is a long-running, deep-seated issue and one that needs to be tackled very, very quickly. That is unlikely to change the position significantly and materially in the current year, but there is an absolute requirement, which is very pressing now, to look at cost improvement in a very different way across the whole system, to look at all of the resources that this organisation and the constituent organisations are responsible for, and to be really clear about what is delivered for funding that is either commissioned, contracted or allocated. And I think that part of that will be around the accountability and the responsibility of individual organisations and what they're delivering against the funds that they are allocated to deliver against. The summary position, as at month 6, is one that continues to show our attempt and our plan to achieve the forecast deficit position. As I've said, there are significant risks, and as we go through the course of this fiscal year, the board will be apprised of those risks, and the board will be apprised if there is any change or any plan to change the forecast position. And at that point, I'm very happy to take any questions.
Thank you very much, Bill. So could I open this up now to discussion? Perhaps I could start with you, Jane, if there's anything that you want to follow on from this.
Well, clearly, obviously, Bill is rapidly, I suppose, getting up to speed on this. And of course, as we said, I mean, the key thing is a bit about how to ensure we've got the delivery against the cost improvement programmes across the whole board, and again, how that's done within a financial framework. So, that's as we move into not just this year, but into next year and beyond, that will need to also lead into our operating planning approach, which perhaps we'll pick up later when we talk about the strategic plan. But, yeah,
thank you.
Lots to do, I think.
Thank you. I wanted to pick up on the right challenge around CIP delivery cost improvement planning. So I think we've talked quite a lot about culture in in this board meeting today, but I do think there is a fair challenge around how we create the right focus on cost improvement planning. Some of that clearly will be delivered through more strategic change programmes. I know we'll talk about that later on, but there is also opportunity to drive efficiency based on things like, best in class elsewhere in the country, and the focus on that is really important. I speak as a chief executive of an organisation where we are challenged in terms of delivery of our CIP. That does not in any way take away from the focus that we have as a board, as organisations, to get maximum CIP delivery. But I think there is a right challenge on us to make sure that we deliver on that expectation.
Thank you. And Fisher.
Thank you, Chair. And in addition to the cost improvement work, we're having an impact analysis on delivery of services given the new developments.
Each cost improvement programme that organisations develop has to have a quality impact assessment. So we would always expect that there's no adverse impact on the quality of care or on clinical safety in terms of the cost improvement programmes that are developed. I think one of the big issues at this point in time within the NHS, not just in Devon but across the NHS, is not so much that dichotomy between the clinical safety aspect and finance. It's about the other targets that we are required to deliver, and those targets in a lot of cases require significant resource. Having said that, I think if we're absolutely honest and look at our current performance, we have not always managed to see performance improve as a consequence of spending money, as a consequence sometimes of spending money that we don't have. And because of that, we will need to look at a fundamentally different approach that relates to accountability for delivery and being absolutely clear about what the outcome is for each of those investments that takes place now and going forward.
James McInnes. James,
Thank you very much, Sarah. And you may think it's slightly strange I'm commenting, but I just wanted to say that this is all very sobering, and I'm sitting as the county council in very similar conversations, and I'm sure similar conversations are taking place in Plymouth and Torbay. And as chair of the Integrated Care Partnership, I'm very concerned that we're all under financial pressure. That's no news, but we need to make sure that we work together to find the solutions. We can't have a situation where trusts, etc., are very concerned about theirs, and the county council is very concerned about theirs, Plymouth and Torbay are concerned about theirs, and we all go off and do our individual things. This is difficult, and it's going to be very difficult, but we must make sure that suitable conversations are across the system. So when we're all making individual decisions, we try and minimise the effect that it has on the wider system. I just needed to say that. Thank you.
Thank you. Jane, you wanted to come in on that point?
Yeah, well, I suppose just to reassure you that we're just in the process of wanting to meet with, trying to work out the best way of doing it, you know, meet with individual local authorities and collectively to understand positions in terms of budget setting, but actually also looking at the saving and cost improvement plans and do that compare and contrast piece and include Cornwall actually in that as well, because obviously that sort of interplay in relation to the Plymouth system and with exactly that point, Councillor McInnes, in terms of ensuring that we don't end up with any unintended consequences, perhaps, about the sort of the pressures that we're in. But actually, equally important to see if there are things that we could do, you know, in partnership. And I'm not suggesting that's going to be particularly easy, but we're just putting in place a process and mechanism to do that. And again, you know, to some extent also, we will need to, and I think we will be encouraged from a health perspective as part of the financial announcements tomorrow to sort of go back and make sure that we're utilising all of our pooled or BCF resources in an efficient way as possible. So, yeah, as I say, because I think we all recognise it's very to some extent, we can't just look at things in isolation at all. I agree. The timelines for that, we need to do that in the next month. So,
thank you. And I think looking at this as a whole system, it's really important that we look at the impact for our BCSE partners as well, because of the impact of cuts on them to our wider prevention agenda, as well as supporting people who are in the greatest distress. So thank you very much for that, Bill. I know this is you're very new in post, and we look forward to hearing updates as this goes forward. Thank you. So what we're asking the board to do now is not to say that they endorse, but to consider, review and discuss the paper, and that's how we will annotate that. Now, just before we go for a break, Jodie has pointed out that I've been very remiss and I didn't ask for the board to acknowledge the minutes. And thank you very much, Kevin, who sent in a number of amendments that have all been incorporated, and are people happy to approve the minutes as per the update. So thank you very much. Right, so we're now going to take a break. We were scheduled to come back at 11:30, but as you can see, we're already past that point. But I think we should have a break. So can we just take a 5-minute break and then resume then? Thank you. programme update, which is going to be led by Liz. And just to clarify in advance that we're asking to endorse the strategic ambition and the design principles of the programme. So thank you very much, Liz, for leading off.
Thank you very much, Sarah. And a detailed paper is in the pack. It's a paper that's been through to all of the provider organisations in Devon and Cornwall, and has also been considered by the Integrated Care Board in Cornwall as well. I think this speaks to a really positive opportunity for us as an integrated system. The establishment of provider collaboratives has been designed to deliver on some of the challenges that we have to meet the needs of our local population, and really creates the right environment for us to work collectively. And it's really good that we have endorsed as a system the establishment of the acute provider collaborative in order to progress some of our ambition for acute services going forward. Very early on, we realised we weren't going to be able to do that without working collaboratively with Cornwall, and I think it is good to note that we have been working alongside them to bring forward the programme that is set out in the paper today. Acute Provider Collaborative is going to be a really important vehicle to take forward our integrated health and care strategy, and we'll be talking about that a bit later on today, but to do so in a way that brings together collective endeavour to do the best for our local population. Why is that important? Because we know that we are managing increased demand. We know we've got so many people waiting far too long for treatment. We know there's also opportunity to deliver some innovation that helps us secure high quality, sustainable services for our population. We set up the Peninsula Acute Provider Collaborative as a committee in common. It has been supported by all of our boards, and very rapidly set an ambition to deliver sustainable services for our local community, ensuring that we do that in a three kind of pronged way. To start off by making sure that we stabilise, then sustain, and then transform using the three horizons model. And that, I think, is going to enable us to design a service model for the future that achieves that objective. From the outset, we've worked very closely with our clinical colleagues. We've been very clear, if we're going to deliver this, it needs to be evidence-based, it needs to be data-driven, but also needs to be clinically led. And that joint work with our clinical colleagues has enabled us to co-produce a methodology that will enable us to progress the work that we've been asked to do through the Provider Collaborative. What we are planning to do is to establish a series of workshops. Those workshops will start taking place towards the latter part of this year. The job of those workshops is to help us design and come forward with the recommendations that enable us to achieve our goal for sustainable services. The Acute Provider Collaborative will receive those recommendations initially. And importantly, as part of the governance, we've established some decision-making frameworks so that we're able to take forward those ideas through our boards and through the ICB. So the paper in front of you really speaks to an ambition to take forward our integrated strategy, a methodology to address the sustainability challenges that we have, and a way of working and a set of principles that we're seeking endorsement from the board today. Thank you. Happy to answer any questions.
Thank you. Judy.
I don't have questions. I have a comment, which is, I think this is a really impressive piece of work. And since Sarah's always telling us to say when things are good, wanted to say that was very helpful. I have one comment, not question. You talk in the about the importance of enhanced primary and community-based services. I think it would be quite important to make sure there is regular consultation with those involved in those services, and some of the structures, which are brilliant in terms of bringing the acute collaborative together, may not have those perspectives just quite sufficiently in the thinking from the beginning. I don't know how you do that without disrupting the collaboration of the different provider units, but assumptions made without. Yeah, I don't need to go into detail.
Can I just add to that, to Judy's point, that I note on the paper that the primary care representative would be added when confirmed. Is that because the initial representative had to withdraw, or is it that this is So that it's an afterthought.
No, it's absolutely not an afterthought, and we're working very closely. So there was an intention. That intention's had to be revisited, but it is very clear that the programme board that is leading this will have primary care representation. It was also, as you'll see, very keen to make sure that we broaden the clinical engagement on this programme of work beyond our medical directors. I have to say our medical directors have been at the leading edge of this and are working really well together to drive forward this programme of work, which we recognise was a key priority. But we also want to make sure that we've got broader engagement from the clinical constituency across our services, and that is also being addressed. Picking up the issue from Judy, because it's absolutely a really important question to ask. One is that whole issue around communication engagement, and really pleased that we've got very good support from Andrew's team to help us be clear about how we get in communication engagement right. We're also supported by our regional colleagues. But this piece of work can't operate in isolation. It has to work very closely with primary care and community services. Likewise, we need to be working very closely with our colleagues in mental health, learning disability, diversity services as well. And we have an opportunity to bring those themes together through the strategy and transformation group that Simon leads. And it's good to see that some of those threads are already being brought together in the work of that group.
Thank you. I know Jane wants to come in, and also Sheena. No.
No, so my point was just to reflect some of the conversations with Cornwall colleagues, just in terms of the next steps about how we get the wraparound and the interplay with with working with them in a joint way. And that's not just in relation to this piece of work, but around joint commissioning going forward. So I know Simon is going to link closely with his counterpart in Cornwall to identify some options that we can take back through this route. Because in fact, the governance diagram in this paper probably is, I'd say, very much now ready to move on to the next iteration.
Thank you. Did you want to comment on that?
I think Jane is said it all. I think we are learning a little bit, so keep providing collaboratives. It's new, and so the work that we're doing with our colleagues in Cornwall is just helping us to further develop the governance and the reporting arrangements. But I think that collaboration is working well, and I'm confident that we'll come forward with a solution.
Thank you. Sheena. Oh, and thanks. Kevin might come in too.
Yeah, this looks great. I'm really pleased about the paper. I've got a question. Again, it's all the devil of the detail, isn't it? But got a question about the data collection. Insofar as quite a lot of the changes, or quite a lot of the key things that make something a bit smoother and the flow better, are quite qualitative in terms of the way in which you deploy your workforce, or you might have a kind of effective care coordinator and all sorts of things like that. That's often quite hard to get from quantitative data. It often involves kind of talking at real team level and across the team to sort of understand the way in which different parts of a specialty will interact together and where those barriers lie. And it's quite tricky. So it's really a case of, is there a sort of desire to do that kind of deep dive discussion with, the range of workers in a particular specialty? And related to that is that when you're working in a particular environment, you don't often sort of see what's wrong or what's maybe not working as smoothly as it might be in another environment. And when you're working in an environment where it's working very smoothly, you might just take that as normal and not be able to identify that kind of secret ingredient. So it is quite complex. So there's all sorts of things that one can do, like visits, like exchanges into, where different people within it's like quality improvement, if you see what I mean. It's more complex than just the quantitative data. So it's really just sort of asking you about your appetite for that, because the membership is quite high level, isn't it? It's sort of very chief exec, medical, and I take on board the need for primary. But I'd also argue that, people like healthcare assistants are often quite important in terms of really understanding what might be where the barriers might lie. So it's just sort of something about the kind of qualitative data, the curiosity.
Thank you, Sheena. And again, a really important set of questions. At the outset, we identified 3 strands of work that we needed to look at, and data was one of them. And we've worked with our clinical colleagues to identify what we think the data set is that we will need to help us work. in this workshops. Also, the workshops themselves are bringing a diverse set of people into the room to make sure that we look at the data with an eye to the experience of delivering those services. We also have met with the HSN just this week to work with them to help us look at what other evidence that we could bring to bear to inform some of the decision making through the 3 workshops that we will be establishing. So really important question, but our intention is to work in that way to make sure that we get a breadth of information to inform some of our decision making. It is really important also to note that, you know, we'll be looking at services not from the perspective of where they will be delivered, but we're absolutely focusing on the service and those care pathways. I think that's also important when you look at the evidence base.
Thank you. And I'm going to take Kevin and Sarah Lou's questions together and because of the time constraints. Kevin.
Thank you. And just echo everybody else, it's just fantastic to have this paper on the board today, Liz, and thanks for what you and others have put into this. But my question is around the ICB board role in this, really. How is the ICB board, what do we need to do to ensure the ambition of this is achieved? And then specifically, I suppose the other side of that coin is the context in which this work is being undertaken is the context of a significant financial gap. And I wonder if there's a role for the ICB to set some of those objectives. So how much of that financial gap are we expecting to be addressed through this piece of work? How much are we expecting to be addressed through other means? That I just want to so that there's kind of references to that in throughout the document, but I just wanted to get a bit more specific on it.
Sure. And I'm just going to take Sarah Lou's question as well, if that's all right, just because of time constraint.
Yeah, again, absolutely brilliant to see this happening. Just a quite an innocent question. The membership, is it deliberately only NHS, or is there thoughts of including local authority and BCSE with the view that we're working together as a whole system?
So I'll come back to that. If I just pick up on the first question. So actually we've got a development session a bit later on, and part of the session I want to start having a broader conversation with us around the role of the ICB in supporting this work, because there's clearly got to be a link between the health and care strategy which we're developing as an ICP, the role of this board in informing and mandating that piece of work, and therefore what the role and responsibility is of the acute provider collaborative. Likewise, the financial framework that we need to operate in to deliver this programme of work needs to also be developed and owned and mandated by the provider, by the boards, and not just this board, but the board in Cornwall as well. So I think there is, and at the moment, I think there's more work for us to do. And if we speak to the different approaches, I think there is a difference in view between the Cornwall ICB and us. And I think we need to work together to understand what that needs to look like going forward. When we think about what it is we're trying to achieve, we think there are 3 issues of sustainability that need to be resolved. And the clinical sustainability of services, the workforce sustainability of services, but also the financial sustainability of services. Now, we've got a strong view that it's the first 2 issues that will be part of the solution to the financial challenges, because we just need to look at services and how we are applying resource to know that that we're spending money to maintain the configuration of our current service model. Do we think it's going to be the whole solution? Probably not. But I think we need to work with Bill and colleagues to be clear about what that financial framework is, and that is work that we've started. In terms of the question about engagement, absolutely. But I think there's a difference between having a group that kind of coordinates the process and makes sure that we're doing the right thing, and then having the right people in the room to help us do the redesign. And I think they're 2 separate things. And I'm loath to have too many people in a room to manage a process. And I'd rather make sure that we've got the right people in the room to help us do the design and also engage with us through the programme of work. And that's kind of how we have worked it through it.
Can I ask, though, that part of that design be actually how we move more out of hospital? And so if you're not including partners who might be part of that with delivering some of those services, perhaps in the BCSE, how can
I think that's, yes. So it's there's absolute commitment to engage with a broader group of people. But I think the terms of reference we've got in the pack here talk to a coordinating group, and we're very happy to take that feedback. But from our planning up until now has been about making sure we have the right people in the room to do the design work and the right process of engagement with a wider cohort to do this all the time, rather than having too many people doing only the core planning. But I've heard the challenge, and we'll absolutely take that away. I think the other bit is we just need to pay attention to the interface with the other strategies as well, which is, I think, is the role of the strategy and transformation group.
Thank you. Sorry, Tracy, it's difficult for me to sit down the end, and sorry to not seen you earlier.
So I think that last point is absolutely right. The key word here is interdependencies. And so I keep thinking about a jigsaw puzzle here and how we put these pieces together and look about how the pieces lock together. But the bit for me is almost what must be true in X programme, or what must be developed in X programme to enable Y to move on to the next stage without rework happening. Yeah. And for me, it still feels like, and it's early days, resolve those key interdependencies so that we've got that clarity. And Sam, I know you're doing a lot of that work, but it's happening in so many different ways across the system at so many different levels. And, there's a reality check that sometimes we'll just move forward and we might have to loop around again on some of those things. But if we can understand, I think that's why these programmes are really important, understand those key pathfinder pieces of work. That's incredibly important. So the next bit for me is what's the timescales, and how do we get that a little bit more granularity around the timescales, which obviously it'll be another phase to enable us to just clock when things might happen. Being in the right room at the right time and not being in every room is so important for all of us in the system, and the trust we put into to enable people to do the right thing. So therefore, for me, there's something about scope. Absolutely. Kevin, your question around, okay, what's our expectation here, and what's the challenge into the system, that element of the system about expectations, because everybody can't be everywhere at once. And then how do we hold each other to account for the part everyone is playing in the system?
Thank you. Simon, you wanted to come back on that briefly.
Yeah, so two very quick points are doing reinforce what Liz has said around the church of people we will have in the design phase, so on the work streams as we get into the co-creation versus the coordination piece. But then strategy and transformation, Tracy has three local authority reps, so we're covering adults, children and public health, and Steve is the rep from covering Devon and public health, acute trust, community, mental health. So it's a good place to coordinate the strategy. We will get some of it wrong, we're bound to, but as long as we've got that overview, we can make sure that we can quickly pull things back together.
Thank you very much. So with the caveats that we've heard about that cross-working, could I take it that we're endorsing the strategic ambition and the design principles? Thank you very much. We come on to item 10 on the agenda, the integrated care strategy update. And this one, we're going to be asking the board to say that they've considered, reviewed and discussed. So Simon, if you could take it away.
Yes, can do. Thank you for that. So just wanted to take to page 141 of the pack. So just so people are conscious of the elements of what we are calling the Devon plan. So the integrated care strategy, which is what we're talking about today, which is the responsibility of the integrated care partnership. So this board is a key stakeholder to that, but it's the ICP's responsibility to sign off or work on the production of that and sign it off. And obviously that's now under the leadership of James McInnes. Our response to that is the 5-year joint forward plan, and you just heard about one of the elements that will be part of that is the acute sustainability plan. This is reference mental health, primary and community care, which Judy and I have been in discussions about. I think what will be important for this board ICP is the integrated care strategy will require a response. So formally, we have to respond on behalf of the NHS. There will be things in that strategy which are not in our gift, and we will want and request and cajole other organisations to respond to that as well. In terms of where we are with the strategy, obviously timing of papers, we sent out where we were at that time. I can give you assurance that the strategy is now at 80 slides, which I'm sure you'll be both heartened that work is in progress and heart sink that it's quite so big. But we have made significant progress. The timeline is that we need to send papers out to the Integrated Care Partnership by the 23rd of November, and a number of you are obviously on the ICP, so you will receive those papers. We have to publish a version of the integrated care strategy on the 19th of December. We are being informed that that is a first draft, so we can further iterate it. But as I said to Sarah earlier, if we're going to publish something, we want it to be pretty much right, don't we, before we get it out there. The thing that I think will draw your attention are the strategic goals, again, which some of you, I know Graham was in the feedback from that strategic leaders event and started to refine the strategic goals. I'll just start on the first one because it's one that we've had conversations about already. So by 2028, One Devon will reduce suicides to 0. We have refined that now, and the current wording of that is we will reduce suicides by, and once we've got the baseline, we will come to a proposal around by how much, by utilising the zero suicide approach, which is the national policy. So that's just an example of refinements that we've made to the strategic goals. Like I said, we were at Strategy and Transformation Group yesterday, which James attended to go through it. Some lots and lots of helpful comments in refining further, and Steve again has made some really good comments. I know there's some in there that are so far away from statutory health and care in terms of how we can support it that we would feel nervous about, and I think those are the ones that we'll want to challenge and refine further. But that's where we are. Sarah, I was happy to take questions. Significant progress since this was sent out.
Thank you. I'm keen to bring James McInnes in first as the chair of the One Devon Partnership. James. Sure whether we've
having trouble with me camera going on. Do apologise. Yes, I attended yesterday. I don't really have a lot more to say because I think there's still quite a bit of refinement to do, and I know you and I are going to meet at some point in the next week or 10 days, hopefully, and go through it together. I think for me is we've got to be careful to have strategic goals, but also to try and make sure that they are achievable. I think, you know, I've always, in my local government experience, you have to have challenging goals because that's what a strategic document's about. But at the end of the day, you need to be careful not to make sure that they're not, you know, there's no point in having ones that aren't achievable. But I think it's important for me sitting on the board here to hear what the conversation is had, because the conversation for me is the one that will take place at the partnership. Thank you.
Thank you, James. And likewise, I feel that I'll have plenty of opportunity to discuss some of the concerns that I've raised about some of the items within this paper. So keen to a chance to do so because they might not have that same opportunity later. Thank you, Graham.
As you already know, I get confused between what I think is the ICB's strategy and the bigger system strategy. So I think I've now got my head around this being the system strategy. And I think the bridge to this, as James indicating, is the doability. And to do that, I suggest two things. One is those proposed goals. It would be helpful for some of those to know where we currently are. So how big is the gap? And then the second piece is roughly what sort of resources and who needs to contribute to fill that gap. So I think those two are going to be really important to bridge between the ICP developing the strategy and the ICB determining how to deliver it.
Thank you. Simon, do you?
Yeah, completely agree, and you'd expect that because I had that conversation with Graham earlier. So just to be clear, this will be, because I'm watching Andrew, this is the only strategy. We will respond and it will be called a plan, because we don't want to get confused with how many strategies we've got in the system. This is the only strategy, but you're absolutely right. We need to know where we are to know how much of a stretch the improvement will be and how much resource we can put into it. The Devon, the joint forward plan will have a really specific chapter which Bill and colleagues will produce, so that we can really get a good feel for how quickly we can make the improvements that we set out in the plan.
Thank you very much. And I can see that Tracy's going to come in, and also Judy.
So I think it's really, really helpful to have this here, and I clearly the conversations at the ICP and in other settings I think are going to be really important. I suppose one of the really important elements is that clarity on whether this is a community strategy for Devon or it is a health and wellbeing strategy. And the reason I'm saying that is the interdependencies with other parts of a bigger system that are doing other things. So public transport. Are you really going to be taking on public transport? Brilliant if you are, but probably you want the Peninsula Transport people and other people who've got parts of the system. So for me, there's something which is about what's in the bigger system of how does life in Devon work? Which are the parts that actually an ICP can do? And actually, what are we looking for other organisations or other partnerships to do? In the same way, those other partnerships and organisations will say, well, if only if we had more people well to work, then we wouldn't have so many job vacancies. So actually, there's a sense of hold each other accountable, but be really clear who's leading on which element of the system. So just doing a little bit of mapping around who is there, I think is very, very helpful in that space. The same with work on housing, the development of housing profiles, housing schemes. Devon's got housing commission that's been set up. And so that sense of this, there's nothing wrong in saying, actually, this is what we're going to do. This is what we're asking you to do. And here are the bits in the middle, and we're going to keep each other in the loop.
Thank you. Really, really important points. I don't think any of us would disagree with that, any of those points. Thank you. Judy.
Just to endorse all of that, because what I was delighted about was we're really starting to work on the wider determinants of health and all these extra things. I had one comment really just about, this is brilliantly ambitious, but we will need a bit of clarity. So if you take the last one on improving outcomes in population health and healthcare, we will have implemented and appropriately resourced neighbourhood teams, which we haven't quite defined yet, that are preventive, proactive and personalised, reducing crisis by 30%. There's an awful lot of definitions to be worked out in that. So, and that's all by 2025, which of course I'm thrilled about. But I think we might be setting expectations that are easily misinterpretable if we're not a little bit careful. I don't know whether to look at you or James. We're not a little bit careful about the language.
Yeah.
As you shape them up. But as of course you've said, it's 80 pages now, so maybe that's all been done.
Yeah. So there will be more definition there. I think the bit for me is about how we respond to that. So in the joint forward plan, how we would configure those teams to be, as we've said, the three Ps, but reduce crisis is in our gift to do that afterwards, isn't it?
Okay.
I think the ambition needs to be that how we define it goes.
Okay, I get it.
Thank you. Jane.
Yeah, no, thank you. And again, just to, obviously we are still in draft, and although the submission will be in December, then we'll have a number of months just to work through. I think it's a number of the points made about those interdependencies. So I think the key thing for me is really trying to, as well as this process, is to still keep checking back with our, people who live in Devon and, make sure it's real to them. And then also for us to, I mean, my ambition would be we would identify 3 or 4 or 5 things that we would want to really get behind. So, it's because, as I say, quite a lot's happening in different places. But, what are the 5 things that only we can get as a partnership? And just go back to the old days of the strategic partnership works, which I know people have been involved with. It's always difficult to do that, but less is more, I think, would be my hope with this work.
Yes, and they always have to be aligned. The health and wellbeing board strategies, what we're doing with the Devon plan. So it's really encouraging that there's close working between those 2 groups. So is there any final points you'd like to make, James, before we move on?
I think that the whole document, the 80 pages, it actually, a lot of it does set out there's a lot of evidence sort of in the document to actually build on what the priorities are going to be towards the end of the document. So I think your comments are very welcome. If anybody else has any other comments, in the meantime, please, don't be frightened to contact Simon or myself or anybody, because it's really important. As Tracy said, this is a document that brings together everything, but we've got to be careful within it, what's within our gift, but also make sure that we do have connections with other things that are in the system that other people are doing. So, we must be careful not to put everything. We can't do everything. It's just not possible. So I do think we will have to hone it down to make sure that we have the number of priorities that we hope we can achieve. We've got to stretch ourselves, but we mustn't have so many priorities that we don't end up achieving any of them. People have always looked at me a bit, and everybody wants their priority in the list. But sometimes you've got to be brave and actually say we're going to have a limited number of priorities, because and set out how we're going to achieve them and on timeline, because that way I think we've got a better way of achieving them. Thank you.
Thank you. Thank you very much, James. So if we could note that we've considered, reviewed and discussed this for the minutes, please. Thank you. So we're going to come next to our section on governance and risk, and we come to the integrated quality and performance report, including urgent and emergency care, elective recovery, mental health and learning disability and neurodiversity, and primary care. And I think, Darren, you're leading on this again. And I know that many of the themes will then be taken up in individual chairs' reports.
Yeah, thanks, Chair. So I'll draw out a few headlines, and I think probably as we've gone through this morning's conversations, I think we've heard Mr. Cox first thing, essentially around the impact of our urgent emergency care. Obviously, John Finn talked about elective care, so I think a number of the metrics again we're triangulated there, and then in terms of patient flow with Simon. So I think the main issues just to draw out is that our 4-hour performance in our emergency and urgent care remains exceptionally challenging, and actually still remains on a downward trend despite the increases in terms of better flow, in terms of discharges. So that remains a concern. Obviously, we've heard that firsthand this morning, but obviously that still remains to have a high composite impact on our category 2. So those are the cardiac episode strokes, the very time critical individuals in terms of an ambulance response. So we continue to work there, and I know Nigel particularly there's some very targeted conversations with both regional and national team and our providers, particularly in the west of our county. I won't go into any more detail on elective care because I think John articulated that well in terms of the conversations earlier. Obviously there are improvements, but we remain off the original trajectory, but particularly in terms of tier 1 for cancer diagnostics, there is some improvement. And again, in some discharges, early days, but again, we're seeing some particular areas. The areas that we haven't covered today, so I think it's worth noting that our COVID prevalence has continued to reduce. The likelihood is that will continue to reduce now to the mid of December and then see a slight peak as we normally see seasonally. But based on the uptake of vaccines, particularly the COVID vaccine programme, we remain in a good position. So this data is actually now 5 weeks out of date. So we're actually closer to 80% of the population have now received their COVID vaccines. In terms of the conversations we're having, particularly linking into the Quality Committee, I think we are looking to do more work within the primary care area, I think, again, we've got some conversations this week around what are the wider metrics we want to really understand around access and quality of primary care. And so that we are, for the Quality Committee, we'll be doing a deep dive into primary care. And that's not because the data is pointing us that way. It's the fact that we haven't got the data at the moment. So arguably, let's have a look at there whilst we're building the data set. And the same with community. So again, community services is an area, particularly looked at patient flow, that we need to do some more elements into SIGS insurance. So both those areas have been agreed via the chair of the Quality Committee. In terms of some areas of improvement, so 111. So again, this has been an area that we've talked many times before, and obviously with PPG taking on the contract 6-7 weeks ago now, we are still not meeting the target, but ultimately what we've seen is a better call response rate. We've seen a better disposition rate, and although we are below the 5%, above the 5% target in terms of call answering at 14%, to remind the board that actually 12 months ago we were at 40% call abandonment rate. So. And this is in the early implementation of the mobilisation of that new provider. So I think that is positive. In terms of mental health, we are seeing the access challenges across the majority of pathways still remaining. That said, that we have seen significant improvements in the improving access to psychological therapy. So the IAPT pathways, those are improving. And I think one worthy of note, because it's also noted nationally, is that the reduction in out-of-area placements has significantly improved. Bringing individuals that are significantly out of area back into the Devon footprint, which I think it has been successfully, implemented across a number of areas. In addition, what we've also identified from a quality perspective, we want to have a look at a little bit more detail into the speech and language therapy and autism weights, because ultimately we've seen a number of trajectories that, and we've seen an increase in referral rates again without the composite improvements. So that is a conversation that we'll be having at the next quality group. And then probably one thing just to flag in terms of workforce, I know we talked about the industrial action this morning, but the Devon turnover remains exceptionally high at 16.9%. Still lower than the national average of 18%, but yet that, considering almost a fifth of our workforce is turning over on an annual basis, off the back of the exceptionally high vacancy factors around the 10%, again, better than national average. Is again a reflection of the impact that it's having on our wider workforce. That is obviously coping with the performance that we're challenged with at the moment. But those are probably the main points, Chair. I'll just draw attention to that probably won't get covered up on future in terms of the subgroup chairs reports back. I'll take any questions.
Yes, Paul.
Just wanted to clarify something in terms of the leavers rate. In the pack, there's a couple of different metrics. So the metric that Darren's referred to are the number of people who have left our organisation. It's likely that they've left to go to another organisation within the system. So the actual rate of people leaving the system is the 7.7. So, some turnover is good between organisations to an extent. The actual leaver rate out of the system is the lower of the two, fortunately. But we're still seeing it getting back to sort of 2017 rates. So you can't ignore the fact it's climbing.
Thank you. Graham.
So since we are on workforce, we've touched upon the finance piece already, but to me the workforce is absolutely pivotal in terms of performance and finance. And I know there's work being done on the dashboard, which I really encourage because I personally don't find I get enough from it. There's a financial table in there that I can't relate. So I think this is a real priority in my opinion. So I'm asking, I guess, Paul, the 2023 workforce strategy date, March, what drives that timeline and what will we get at that point? Because to me, that's a real imperative.
Yeah. So the timeline has been driven by the need to deeply engage with the providers within the organisations. So we've got a set of principles that were agreed middle of this year in terms of the things that we will focus in on in terms of the size and shape of the workforce for the future. The work that's ongoing at the moment is that engagement with providers within the system. So that's what's driving that date. There's a more sort of there's an earlier piece of work around making sure that we've got the right focus on the operational plan for next year. And Bill and I have had a discussion already about making sure that we're exceptionally clear very soon, this side of Christmas, as to the workforce growth or otherwise that we can accept and expect to see or otherwise for next year. Because we entered this year's operational planning round in a way that wasn't clear enough in terms of the signal around workforce growth or not. So there's the workforce strategy piece is where do we want to see the size and shape of the workforce being in sort of 5 years' time. There's a much earlier piece of work that we're on with now around setting the right target for next year's operational plan. Because as you know, as we discussed last time, what we've tended to do every year is increase the workforce pretty much in line with operational sort of demands, or indeed higher than that, which we clearly can't be in that place.
Because I know we've got industrial action potential, confusing it, but it just seems to me that this is a priority. It's in space. Thank you.
Thank you. Sarah Lou and Frank, I think would like to come.
Can I just pick up on the out of area placements and beds? Are we tracking two things? Are we tracking where actually that we accept that it is appropriate for them to be out of area because it's better for them to actually receive care? We don't have it here. So are we able to have those figures in part of this? I think that's really important because there are some people that perhaps, I might even argue are currently in area that perhaps would be better out of area. Because we don't have the available services for them. So I think
so there's appropriate and inappropriate. We do monitor both.
Okay.
Yeah, and I think the other element is your comment about sufficiency. So actually, there are areas that the individuals that may be in area but inappropriate but out of area.
Yeah.
So there are three.
Yeah.
Phases to this.
Yeah, definitely. With the workforce, I'm just thinking in my curious way that I do. There may be industrial action coming. Is that a really good time for us to perhaps speak to all of those staff that are looking to take industrial action about what else we can do for them apart from money? Would that be, they're going to be on strike. They're going to be available if it happens. Is that a good time to be asking those questions? Money, what else?
Yeah, I mean, I think we know it's important to people already, to be honest with you. And money is something that, as a system, we can't do anything about. But I think all the things we've talked about earlier in terms of good culture, good working relationship, people tend to leave, their kind of local line management rather than leaving the organisation. So that local focus on great leadership tends to be the defining factor. So I think it probably wouldn't be a great time to ask sort of bigger questions than that, because to be honest with you, we haven't got a lot in our kit bag in terms of giving them sort of things that may come out as answers.
Yeah.
All the engagement surveys we do, all to that to be the thing that tends to be the deciding factor as to whether you stay or go.
Thank you. Frank.
Thank you. For me, what I said earlier about we've got to be careful about what we ask of the system is highlighted in some of this stuff. If we focus on the mental health report, my perception trying to get people into the mental health system, both children and adults, is the criteria go higher and higher, and that is more and more difficult. So if we measure the number of people actually in the system, what we're actually missing is all of those who haven't even been able to access it. And that is where the real problem lies. So, how do we actually identify the real problems rather than what we're thinking we're measuring out correctly? And that would then come into the whole commissioning of how mental health services are provided. And, the fact that you have to hit an absolute threshold before you're seen is compounding the problems. So, people will respond in certain ways depending on what we're measuring and asking them about. And actually, for me, for mental health, it's asking the wrong question.
Thank you. Liz.
Okay, I think my point builds up a bit on what Frank's saying. I think it's really great to see this report and it's really growing, but it's the so what test. And it's how we bring the different data points together and what that's telling us. And I think when you start asking that question, you wonder what are the other data points that we might want to see. And some of it will be about people waiting, but some of it will also be about some of those community metrics. I think this is great as where it is, but the real test of how good it is about how we pull that information together, including money. So what does that mean we're going to do then? Because at the moment it doesn't give me enough to be able to do that well.
Yes, and building on that point, and also Frank's point, I met with VCSE partners last week, and a very significant point that came out of that meeting was the difficulty they have escalating people where they're carrying quite high levels of risk, getting statutory services to respond when they have concerns about somebody, and that's we risk losing them unless we can provide that reassurance. Sarah Lou, did you want to?
Yeah, I was just going to say what Liz is saying, that we need to capture that data, don't we, of what's going on in the community and what level of risk they're holding in the community. But also, again, where is it appropriate? You know, are we splitting it appropriately between us of who is seeing which people are? I mean, if you said to me, and I work really closely with CAMS, but if you said to me, what is their current criteria? What are their current thresholds? What do they see as their expertise? I don't think I could still answer that. So if you're a member of the public, how do you know if CAMS is the right place for you to go to, as an example, or could somebody within the community help you? So I think there is something about really thinking about using that Thrive model to think about where should people be sitting, and are they being seen in the most appropriate, the most we can think about the finances around it as well. You know, I think it would make a big difference if we understood who is being seen where.
And further to that, just to update the board that the One Devon Partnership is going to be looking at this area in depth in January. So it's on that. Could I just ask a quick question as well, if I may, around it's on page 13 of the report on the planned care 104-week waits, because we are obviously major outliers on this. But I was interested to see that we're 155 adverse to the trajectory that we had ourselves submitted. So I just wanted to explore whether that's getting worse, but also the point at the end there about validation and people who choose to postpone their surgery being removed from the waiting list. And some people are postponing for not because of convenience reasons, but because there are many other factors in their lives, and they'll want to be reassured that they won't then go to the back of the queue, because it mentions that they'll be removed until they're in a position to then have this. But they're unlikely to do that if they think they're going to go right to the very back of the queue. So I just wondered if you could actually talk a little bit more about how that works in practice, so we can be reassuring.
Yeah. So in terms of that second point, Sarah, I think it is an interesting comment. I think where we are with it is around clinical validation. So individuals will rejoin the waiting list. They won't go to the absolute. They're not joining right from day one as a new referral. It'll be clinically validated in terms of priority. So ultimately they will then, may not necessarily come straight back to the front of the queue, but ultimately will not be going to the back. It will be all done on clinical validation. I think it's fair to say that the trajectories that we set have moved significantly in both directions over the last few months. I mean, John, Finn and the team are meeting pretty much now, the regional team, on a day-to-day, pretty much weekly basis, validating this. And of course, it is a movable feast because individuals start, and particularly the priority areas. So I think it is an exceptionally challenged position. I think probably the fair thing also to say is as we move into and if there is industrial action, these numbers will shift significantly in a negative direction as well.
But just to be clear, when people rejoin, they'll still be in the 104-week wait category, because that gives them access to others.
They don't. We want to use the word stop the clock. It's not stop the clock, but they won't be. They're not removed as in physically removed from the waiting list, and they then suddenly become a 0-week wait. They will still be within
Yes, because that opens other choices up to them. Thank you for that point of clarification. Are there any other colleagues wanting to come in on the report? In which case we'll say that we've reviewed and discussed on this. And we come now to the individual committee reports, and these ones we're being asked to take as read, and that any escalations are brought to our attention. So Kevin with the Finance Committee was going to lead off.
So this is a verbal report, but the committee met just last Wednesday, so we didn't have time to get a written report into the meeting. So just to highlight a couple of things, I mean, we did review the IQPR and the financial report, which have been presented to the board meeting today. We did review progress on the financial recovery plan, which Bill referenced earlier in this meeting, and we'll be reviewing a more complete plan at our meeting in December. We had a brief reference to the action from the last board meeting, which was that the committee explores the establishment of a health and equity committee. So I'm taking that forward with Sheena to start to outline what that might look like, which we hope to bring back to the next finance committee and then ultimately into a recommendation to the board. And then looking forward to 2024 financial planning, the point which actually Graham's just made around the workforce was made in the committee, the importance of us getting the financial planning and workforce planning aligned, just to get a confident plan for 23-24. And Paul and I have had a small discussion about that as part of this meeting. And then finally, we reviewed the tender process relating to home oxygen services, which the chair referenced earlier, and we'll be taking that into the private session of the board later under a commercial in confidence heading. Happy to answer any questions if there are.
Thank you. Does anyone have any questions for Kevin? Thank you very much, Kevin. We come next to audit and risk, and Graham.
Thank you. So there is an internal audit programme that's on track. It's reported back on the closing 3 months of CCG and it's come back with significant assurance. The thing they do flag is that the assurance process and the risk process will need updating and hasn't been thus far. I think we all know why that's a bit behind. There was a very helpful board session, of course, the other day on that to take it forward. The committee has seen the first draft of the policy and framework. And I think we were quite keen to get beyond defining the process and the policy and move into content as we can. So that's work ongoing. The one that I must report, though, which is problematic, is the external auditor position. And Bill, I think you can probably fill us in on an update on that. Mm-hmm. But you may recall that Grant Thornton declined to propose to continue to be our auditors. We put it out to procurement, and that procurement has just closed with a negative response. Bill, do you want to sort of add anything close to the?
Yes, Graham. So the position is that, as Graham said, we went out to tender. This was for completion of the 3-month period of the CCG and the 9 months of the ICB in the first instance. We have not got an external auditor. I have just contacted the region to ask them what the next steps are. I don't think we're the only organisation that finds ourselves in this position, but the likelihood is we'll need to make contact with the National Audit Office and determine what happens next, and they will, in all likelihood, appoint an auditor. The reasons given for not bidding, Grant Thornton, the existing bidder, cited work that they're doing at RDUH as a conflict. And I had personal contact with KPMG, who we were very confident would bid, and they then declined to bid because they wanted to focus on advisory work as well. So most of the firms in the market are focusing on advisory work. Whether that's because they think there's going to be a lot of financial recovery work going forward, I don't know. I also know that within the market that a number of the firms are looking to separate their assurance and advisory work, the Channel 1 and Channel 2 work. So unless there's a change in the audit guidelines that allows firms to actually do both. So my experience in Bermuda is they could. That's a very different jurisdiction. Or we get one appointed for us by the National Audit Office without an auditor for this year's accounts, and that's something that can't continue.
Very concerning. So you'll report back to us on
Yes.
progress.
At least I think we have used best endeavours to secure one, and the fact that we can't is a function of the market. It's not us specifically, really. So we'll report, yeah.
Thank you. Any other questions for Graham? No? Right, we'll come next to Quality Performance Committee and Hisham.
Thank you, Chair. So we escalated the East Kent Maternity and Neonatal Services report, and that's been discussed in detail earlier. The only thing I would add to that is, given the impact of the report on both members of the public and providers, would there be a system-wide communication strategy of the actions taken by the system and the follow-up on these actions? That's just a question. The other bit that I want to highlight is that we discussed the IQPR report in great detail, and the theme that goes through all of those domains in the IQPR, how we would get as a Quality and Performance Committee assurance on the actions that have been taken. So if we take, for example, elective care areas like cancer weights and diagnostics, there hasn't been the improvement that was expected, and there have been a number of actions taken. How are we going to get assurance on these? The same goes for mental health services, particularly children and young people, services eating disorders, to point out one specifically. And likewise, very similar, speech therapy for children and young people as well. So all of these areas have had actions taken about them, but we need to get assurance on the effectiveness of these actions. And I'll stop there in the report. There is a report that I assume colleagues will have read. Thank you.
Thank you. Are there any questions for Hisham?
Only, Chair, I'd be happy to take forward to Hisham your first point around communicating the East Kent reports. I'll work with that and Nigel have that.
Thank you.
Thank you. And I know, Hisham, we've discussed the Quality and Performance Committee taking forward having sessions with individual providers to actually question them further about.
Yes, in particularly areas of emergency and urgent care, we need to take some of the more detailed discussions as well, and we'll do that. Thank you.
And for you to escalate to this board where you're not satisfied with responses or feel that you can give us assurance. Thank you.
Thank you.
Thanks. No, right, and then we come on to the People and Culture Committee. Unfortunately, although Tandy is following from outside today, it's just not been well, and Judy has very kindly offered to present on behalf of the People and Culture Committee and also the Primary Care and Transition Committee. So thank you, Judy.
So on the People and Culture one, I think it speaks for itself. There's some really good discussions and information. There was no item of concern to be escalated to the board, but those of us who attended could answer any questions if people have any. I think I would just reassure Graham that this group is really taking seriously the issues around workforce that you were talking about. Okay. On the Primary Care Committee, there was one item I was asked to raise at the board, and that is that during our finance report, we were advised, I knew in the past, but actually had forgotten, forgive me, that in terms of primary care funding, that is that contract funding, we are below target in Devon. And although they have given us some money this year from the centre, which is called convergence funding, there is no guarantee of the timescale for getting to the position where we would be at our target level. And I know that these targets get changed quite often. But in this climate of us all talking about how much we are overspent everywhere, the committee felt it was appropriate just to remind ourselves. It's not masses of money. I think it's 6 million, but it's a little bit below. So I was asked to raise that.
Thank you. Are there any questions for Judy?
I mean, the only thing I'd say in response to that is that there are a number of areas where we know we have to do something around equity and fair shares, and this is one of those. And there's a significant amount of work that looks at the disposition of resources between localities and between sectors. And again, that's something that we'll need to bring forward in the financial framework for the coming year and beyond.
Yeah, this was not intended, by the way, to be any criticism of the finance team. We get fabulous support from the finance team. But it was just, you know, we're also full of this sense of overspending. That's the issue, but I'm glad, Bill, that there's work going on it.
And the fair shares issue is going to come back to the board. So thank you. I've got Sheena to ask a question.
Yeah, hi. In light of the kind of continued uncertainty about the Cavell Centre and the fact that you've got 3 primary general practices that really do need, at least 2 of them, I think, but all 3 of them need to shift premises. Is this not something that should be a kind of on the committee list as a sort of risk, or is it on the risk register for the committee?
We have a massive risk register, and the issue of estates is on it. I can't quote you the number or, you know, the risk number or whatever. I would have taken the opportunity, if I could have, to say how distressed we are about the fact that we can't fund the Cavell Centre at the moment. Because if we want to get to better integration of primary care practices and community services, we can't assume that the practices on their own will do this. We need to be facilitating estate development to enable that. And I know we all know that. And so, yes, we do discuss estates quite regularly at the committee. And there is support going on for other practice developments too. We might add that to the estates section on I'll talk to Bill about the finance report and adding primary community estates to that too, so everybody knows what the picture is.
Thank you. And within my chair's report, Sheena, I have highlighted the updated position on the Cavell Centre because it simply isn't possible for us to finance within our existing capital budgets, as was suggested by the Minister. I don't know whether, Tracy, you want to come in and say anything about Cavell as well yourself?
Yes, well, I think taking my board hat off and putting just a Plymouth hat on, I think Plymouth is really, really grateful for the board's support for what we're calling West End Health Hub. And I think actually by all working together, the fact that 18% of people that go to ED are from that ward that will be served by that is feels to me like a really important statistic that we have to keep getting over to the Minister. We've written again. I think actually everybody holding firm on this. I know we're having some further conversations about other opportunities for finance. So I think we just have to keep working at this both nationally but also locally to see what the art of the possible is going to be.
And I think it's been a very good example of joint whole system working. Thank you. Yes, thank you.
The Cavell Centre, I think, is not only a risk for primary care, it's a massive reputational risk for us. It is vitally important if we're going to follow the principles on which ICSs are established, which is dealing with health inequalities and population health management. And I know capital spend for this year of the 80 million was allocated. I don't know where the decisions for next year's capital spend allocation are going or the year after. But, if we don't deliver on this, I think it's quite a big problem for us.
Thank you. Right, so we're going to now, so it's to just say that we have taken all of these as read, and now we're coming to the action log part of the committee. If you'd like to see those, most of these we have a request to close. We have 3 items that are still in progress. They're self-explanatory within the paper. So I'm just asking the committee to approve that this is where we are with those. Thank you very much. Right, so I think at that point, we've come to public questions. I'm told there are no questions this month that have been raised, but I just wanted to reiterate for the record that on publication of the agenda, members of the public are invited to submit questions related to agenda items 2 days prior to the meeting, and appropriate questions and responses will be shared during the meeting and published on the website following the meeting. Now, just got an item usually where we invite Cornwall and the Isles of Scilly to give us an update. Unfortunately, Kate is unwell and joins today, but Jane, do you want to add anything?
Nothing to add really. I mean, other than that, just for information exchange as such, but we are trying to organise a sort of joint meeting with sort of initially with execs across Cornwall and Devon, but I'm also having attended the Cornwall and Isles of Scilly board last week. I talked to a number of non-execs who are quite keen to link up across the different areas, workforce being a key one. So I think we need to test that out a little bit with John Govick and Kate Shields when she's back. But certainly, I mean, there's so many things that it's really important that we do together. So, and certainly, as I say, quite an appetite. So that will probably be something we will start to get in place either, well, in the new year, really. I think we might hopefully try and meet as execs before Christmas, but then as non-execs, we can talk through a little bit of a plan on that. And that was it, really.
Thank you, Judy.
Can I just ask, when we hear of good ideas from Cornwall,
pinch with pride.
We pinch with pride. Is that what we say?
Yeah.
And adopt.
Oh yeah.
But this GP, think of me, thing sounds very interesting, and it is an issue we have been concerned about since the government did their initiative on you can have an appointment with your GP. And we're trying to get people to understand that sometimes it's much better to go and see the physio or the pharmacist or someone. So if we can, I don't know if it's a good scheme or not, but
yeah, well, no, exactly, and it's got a strap line. I mean, we've to some extent, which is helpful. I mean, we've been having a lot of conversations exactly that in terms of how we can, and we've got a session, particularly in Plymouth on Friday. I think, again, a bit about how we can start to have a coordinated communication campaign or approach, because, as you say, there's some fantastic examples of clinicians who are working, or non-clinicians actually, as part of the multidisciplinary team within PCNs and practices that I could see when I go out, and we need to do quite a lot more just to shift people's perception of because generally, and there's some real, not coming from the clinicians, but actually from patients or people themselves, about the fact that they'd rather go and see their practice nurse rather than going to see the doctor. And we're doing quite a lot of work as well with our MP colleagues about trying to ensure that they are also helping to champion that. And I think I mentioned earlier that new Secretary of State, and I've just had a text to say GP access is top of his list, and I suspect it's not necessarily how we would want to position GP access. So there is absolutely more work to do. But yeah, no, I wrote copious notes when I went to the Cornwall board, and there's some other things that we might want to just talk a little bit about, pinching with pride in terms of how they structure their agenda, and also perhaps have some more reports or some more contributions, not to end up with a whole long list, but actually I'm just conscious we've got member partners looking at Tracy and Steve, and obviously Liz has talked today about some of that work, but how do we ensure we have everybody's contribution, as well as Sarah Lou and Frank. So yes, and equally, it's a two-way street, isn't it?
Yeah.
Yeah, this is a really interesting conversation, and it's kind of, I'm going to sound like a broken record player, but I'm kind of really convinced, given the stress on the system, of the need to more proactively engage and activate our patients. And, you know, as Jane was saying, sort of encouraging patients perhaps to think of different, you know, different providers to go to. But for me, this is actually partly, it's about comms, and it's about using comms in a really interesting way, not leaflets, but, you know, videos and exciting sort of interactive games and all sorts of things that you can do. But I never hear very much about what we do as a, you know, in comms as an organisation, and also whether the, you know, with something like comms, it's the sort of thing that you really ought to be doing at scale. You know, you reach economies of scale. So what are we doing with regard to our communications and our patient engagement and activation and all the things that that frontline staff will talk about quite a lot, but I'm not too sure what we're doing.
Bring Andrew in here.
Yeah, so Sheena, I think what would be good, because there's a lot going on and we're doing more and more work across the peninsula as well with fellow colleagues. So I'd be happy to bring that to a future board, whether that's a development session or indeed in public. So I'll be happy to action that.
Thank you. So we'll put that on the forward planner. Thank you very much, Sheena. And is there any other business that colleagues would like to raise before we close? Thank you all very much, and we'll close now for.